Personality Disorders: The Intricacy of Schizoid and Depressive Disorders. Written by Derek Halfson. Narrated by Rory Young. Chapter 1. Schizoid Personality Disorder. Schizoid personality disorder is a pattern of indifference to social relationships, with a restricted series of psychological expression and experience. Individuals with schizoid personality disorder rarely feel there is anything wrong with them. The disorder manifests itself in adult years through social and psychological detachments that stop people from having close relationships. Individuals with it are able to work in daily life, but will not develop significant relationships with others. They are normally loners and might be prone to excessive fantasizing and forming attachments to animals. They might do well at singular jobs others would find unbearable. There's proof suggesting that the disorder shares an underlying genetic architecture with schizophrenia, and social withdrawal is a quality of both disorders. Most importantly, people with schizoid personality disorder are in touch with reality, unlike the ones with schizophrenia or schizoaffective disorder. Signs. According to the DSM-5, symptoms of schizoid personality disorder include the following: does not desire or enjoy close relationships, appears aloof and separated, stays away from social activities that involve significant contact with other people, usually chooses singular activities, little or no interest in sexual experiences with another individual, lacks close relationships other than with instant loved ones, indifferent to praise or criticism, shows psychological cold, detachment, or flattened affect, exhibitions little visible change in mood, takes pleasure in few, if any, activities. Causes. The reason for personality disorders isn't known, but a greater risk for schizoid personality disorder in families of the ones with illnesses on the schizophrenia spectrum suggests that there is genetic susceptibility to developing this disorder. Treatment. Little research has been done on the treatment of schizoid personality disorder. This is partly just because people with this diagnosis normally do not experience solitude or compete with or envy people who enjoy close relationships. Medications are not normally advised for schizoid personality disorder. Nevertheless, they are in some cases used for short-term treatment of extreme anxiety states related to the disorder. The presence of anxiety, generally brought on by fear of other people, may mean that a health diagnosis of the related schizotypal personality disorder is better suited. Individual treatment that effectively obtains a long-term level of trust may work, as it helps people with the disorder to establish genuine relationships, in cases where this is desired. Individual psychotherapy can slowly impact the formation of a real relationship between the patient and therapist. Long-term psychiatric therapy is harder to pursue because this disorder is hard to ameliorate. Rather, treatment needs to concentrate on basic treatment objectives to reduce current pushing concerns or stressors within the individual's life. Cognitive restructuring might appertain to attend to certain kinds of clear, irrational thoughts that are adversely affecting the patient's habits. That restorative plan ought to be clearly described at the onset of treatment. Chapter 2. Schizotypal Personality Disorder. Schizotypal personality disorder is an ingrained pattern of thinking and conduct marked by uncommon beliefs and fears, and difficulty with forming and keeping relationships. People with schizotypal personality disorder are uncomfortable with close relationships and may show eccentric conduct. Speech might include discretions, weird usage of words, or display magic thinking, like a belief in clairvoyance and strange fantasies. Patients generally experience distorted thinking and stay away from intimacy. They usually have few, if any, good friends, and feel nervous around complete strangers, though they might wed and maintain jobs. The disorder, which might appear more frequently in males, surface areas by early the adult years and can exacerbate anxiety and depression. Symptoms. People with this disorder stay away from socializing and obtain little satisfaction from communicating with others, a hallmark of the schizoid character too. Those with schizotypal character, however, manifest strange beliefs, aliens, witchcraft, possessing an intuition. According to the DSM-5, the signs include discomfort in social circumstances, odd beliefs, dreams, or preoccupations, odd behavior or appearance, odd speech, troublemaking, keeping friendships, inappropriate display of feelings, suspiciousness or fear. Causes. As with most personality conditions, the reason for schizotypal personality disorder is unknown, but there is an increased incidence among family members of those with the condition, as well as those whose loved ones are on the schizophrenia spectrum. The prenatal risk aspects that really apply to schizophrenia are also pertinent to schizotypal personality disorder, and that includes maternal direct exposure to certain infections. Drug use may be a contributing element for people already in danger of developing this disorder due to a hidden hereditary predisposition. Treatment. Schizotypal patients rarely initiate treatment for their disorder, tending to look for a remedy for depressive problems instead. There are those that might be helped by antipsychotic medications, but treatment is preferable for most. Just because the characteristics of this disorder cannot be fundamentally altered for the ones with moderate to severe cases, treatment is typically targeted at helping people with this disorder establish a gratifying singular existence. Behavioral modification, a cognitive behavioral treatment technique, can allow schizotypal personality disorder patients to remedy some of their strange ideas and behaviors. Acknowledging problems by watching videos and meeting with a therapist to enhance speech practices are two reliable approaches of treatment. Chapter 3. Schizophreniform Disorder. Schizophreniform disorder is a psychotic disorder diagnosed in somebody who shows signs of schizophrenia for the better part of at least 1 month, but for less than 6 months. If the signs continue for 6 months or more, the diagnosis is changed to schizophrenia, or in some cases, bipolar or schizoaffective disorder. Somebody with schizophreniform disorder cannot differentiate between what's real and what is pictured, to a degree that affects their thought process, behavior, emotional expression, and interpersonal relationships. To meet the criteria for schizophreniform disorder, the signs should not be as a result of medication or recreational drugs, or to another medical or psychological issue. Symptoms. According to the DSM-5, schizophreniform disorder can be identified if at the very least 2 of the following signs appear, and one of the 2 symptoms is deceptions, hallucinations, or disorganized speech. Delusions, thinking of that people are talking about you or spying on you. Hallucinations, hearing or seeing things that don't exist. Disorganized or ridiculous speech. Strange or catatonic behavior. Lack of health or lack of interest in day-to-day activities. People with schizophreniform disorder usually withdraw from loved ones and keep away from social activities. Schizophreniform disorder usually results in a loss of regular living and social skills, and significant issues at school or work. Like schizophrenia, schizophreniform disorder affects women and men similarly, but onset is normally earlier in men, typically appearing between the ages of 18 and 24. In contrast, start in women is more common between the ages of 24 and 35. It is very important to seek analysis and treatment as soon as several essential symptoms appear, as the prognosis for a full recovery is best with early intervention. Causes. The cause of schizophreniform disorder is uncertain, but might be connected to genetics, irregular brain structure, or circuitry in areas that include perception and/or an environment or circumstance that starts signs in a person who is genetically inclined to develop the disorder. Poor interpersonal relationships or extreme tension might set off symptoms of schizophreniform in the ones who are vulnerable. Children with parents affected by schizophrenia spectrum disorders might be at higher than average risk of developing the condition themselves. Treatment. Psychotherapy and antipsychotic medications are the pillar of treatment for schizophreniform disorder and are critical to prevent the development of schizophrenia. Cognitive behavioral therapy is consistently used to help those on the schizophrenia spectrum comprehend the disorder and offer practical ways to cope while enhancing social and problem-solving abilities. Other types of talk treatment that take a favorable method may be equally effective, at least in the short term. If violent or self-destructive signs appear, hospitalization might be necessary. Family therapy can also help loved ones deal with the disorder and learn effective ways to help. Chapter 4. Schizoaffective Disorder. Schizoaffective disorder is a believed disorder that includes both psychotic functions, as seen in schizophrenia, and mood symptoms that might be either depressive or manic in discussion. The psychotic and state-of-mind signs might happen together or at different times. Schizoaffective disorder is diagnosed in fewer people than is schizophrenia. Approximately 1% of the population worldwide will be diagnosed with schizophrenia, 0.3% with schizoaffective disorder. Since the frequency of schizoaffective disorder is low and just because it includes both state of mind and psychotic features, the disorder can be hard to diagnose. While at least two primary criteria for schizophrenia must exist, a crucial difference is that people with schizoaffective disorder are more functional concerning self-care and in their capability to engage with others. Signs. In order to be identified with schizoaffective disorder, the DSM-5 specifies that at the very least, two psychotic symptoms must exist, and also state-of-mind symptoms of a particular duration. The symptoms of psychosis, which correspond the primary criteria of schizophrenia, include hallucinations, misconceptions, chaotic thinking, speech, or behavior, which may include catatonia, flat affect or anhedonia, also called negative signs of schizophrenia. The state-of-mind symptoms that must exist include mania, racing thoughts, rapid speech, unusual or risk-taking conduct, depression. Simply because the symptoms of schizoaffective disorder overlap with those of bipolar or depressive disorder and schizophrenia, the condition can be hard to identify. Schizoaffective disorder is identified when there's a time period with a major depressive or manic state of mind, and at the same time, at least two psychotic symptoms appear, or when there's no sign of a major mood disorder, but clear symptoms of schizophrenia psychosis continue for at the very least 2 weeks. While there might be time periods when there are no signs of a state of mind disorder, they exist most of the time. Causes. Although the cause is unclear, genetics is thought to contribute to schizoaffective disorder. People with a parent or caretaker or sibling who has schizoaffective disorder, schizophrenia, or bipolar disorder might be at higher than average risk for developing this condition. The application of psychoactive drugs and extreme or persistent tension may add to start for the ones who have an underlying predisposition to develop schizoaffective disorder. Treatment. Treatments for schizoaffective disorder are similar to treatments for schizophrenia. Antipsychotics are the mainstay of treatment. State-of-mind supporting drugs and antidepressants are often prescribed too. The disorder can go into remission when the correct medication is taken. Treatment might also include psychiatric therapy. like cognitive behavioral treatment to enhance the individual's grasp of the condition and help him or her manage daily life, and family-focused treatment for the person's members of the family. Chapter 5. Depressive Disorders. Depressive disorders are defined by relentless emotions of sadness and worthlessness, and a lack of desire to participate in previously satisfying activities. Depression isn't a passing blue state of mind, which nearly everyone experiences from time to time, but a complicated mind-body health problem that interferes with daily functioning. It not only darkens one's outlook, it is typically marked by sleep issues and changes in energy levels and appetite. It alters the structure and function of afferent neuron so that it disrupts the way the brain processes info and analyzes experience. Despite emotions of despondence and insignificance, depression is a fixable condition. It can be treated with psychiatric therapy or medication, or a mix of both. Depression is a common condition in contemporary life. According to the National Institutes of Health, each year more than 16 million adults in the United States experience at the very least one episode of major sadness. The possibility that a person will develop sadness at some point in life is roughly 10%. Extended social tension and major disruption of social ties are understood risk elements for depression, and significant negative life events, such as loss of a loved one or loss of a job, increase the subsequent risk of sadness. Substantial hardship early in life, like separation from parents or caretakers, or parental disregard or abuse, may produce vulnerability to significant sadness later in life by setting the nervous system to over-respond to stress. Definition: a depressive disorder is a condition that involves the body, state of mind, and ideas. It disables inspiration and hinders regular functioning of everyday life. It usually triggers real pain both to the person experiencing the mood disruption and the ones that care about him or her. A depressive disorder isn't the exact same as a passing blue mood. By definition, the signs must be present for at the very least 2 weeks. Nor is it an indication of personal weakness or a condition that can be willed or wished away. Anxiety tends to be episodic, with bouts lasting weeks or months. Though signs tend to remit spontaneously in time, some form of treatment is very important to reduce the likelihood of recurring episodes. Appropriate treatment can help many people who experience sadness. Depressive conditions come in different forms, as holds true with other health problems, such as heart problem. 3 of the most common types of depressive disorders are described here. Nevertheless, all forms are marked by variation in the number of symptoms and their seriousness and persistence. Significant depressive disorder, or significant depression, appears in a persistently miserable state of mind, accompanied by certain other signs that interfere with the ability to work, study, sleep, eat, and enjoy once pleasant activities. A disabling episode of sadness might happen only once, but more commonly happens several times in a lifetime. Depression is more than a condition only from the neck up. It also influences the function of many body systems. Scientists have established, for example, that immune function is typically jeopardized in depressive states, and impaired immune function might in part underlie the link of depression to such other disorders as heart problem. Dysthymic disorder, or relentless depressive disorder, is also called dysthymia, includes signs of sad or down state of mind most days for the majority of the day over a long term, 2 years or longer. But the depressed state of mind is not disabling, though it impairs functioning to some degree. Many individuals with dysthymia also experience major depressive episodes at some time in their lives. Some forms of depressive disorder involve minor variation of features or develop under particular scenarios. Premenstrual dysphoric disorder manifests in the week before the start of menses, subsides within days after onset of menstruation, and remits in the week after menstruation. According to the National Institutes of Health, 3 to 8% of women of procreative age meet strict requirements for premenstrual dysphoric disorder. Significant sadness with psychotic features, or psychotic depression, occurs when a serious depressive health problem is accompanied by delusions and hallucinations. The psychotic functions might be mood congruent with the depression, that is, consistent with the depressive themes of personal inadequacy, guilt, nihilism, or death. Or the misconceptions and hallucinations may be mood incongruent, not involving such depressive themes. Major sadness with postpartum start or postpartum depression is identified if a woman develops a major depressive episode during pregnancy or within 4 weeks after delivery. It is estimated that 3 to 6% of women experience postpartum sadness. Significant sadness with seasonal patterns or seasonal affective disorder, SAD, is characterized by the beginning of a depressive illness throughout particular times of the year. Typically, the depression develops throughout the cold weather, when there is restricted natural sunlight, and completely remits in the spring and summer season. In a minority of cases of major depression with seasonal patterns, the sadness occurs during the summer months. SAD may be effectively treated with light treatment, but almost half of the ones with SAD don't react to light therapy alone. Antidepressant medication and psychotherapy can lower unfortunate symptoms, either alone or in combination with light therapy. Signs. The following signs and symptoms are catalogued by the DSM-5 as signifiers of major depressive disorder, and at least 5 must exist throughout the prolonged period of low mood or loss of enjoyment in once enjoyable pursuits. Not everybody experiences every symptom, nor do people experience the exact same symptoms to the exact same degree. Signs may vary not only between people, but gradually in the exact same individual. Relentless, miserable, restless, or empty state of mind most of the day, most days. Feelings of worthlessness or extreme guilt. Loss of interest or enjoyment in activities that were once taken pleasure in, which includes sex. Consistent loss of energy or tiredness. Trouble thinking, concentrating, recalling, or making choices. Sleeping disorders, morning awakening, or oversleeping, hypersomnia. Significant change in appetite leading to unintended weight reduction or weight gain. Observable psychomotor agitation or restlessness, or psychomotor slowing down. Feelings of hopelessness or pessimism, reoccurring ideas of death or suicide, suicide efforts. Causes. There is no single reason for depression. Rather, evidence suggests it results from a mix of genetic, biologic, ecological, and psychological aspects. Research releasing brain imaging, such as magnetic resonance imaging, MRI, and other innovations, shows that the brains of people who have depression look different than those of people without sadness. The parts of the brain accountable for regulating state of mind, thinking, sleep, appetite, and behavior appear to operate unusually, but these changes don't expose why the sadness has occurred. There are many pathways to depression. Genetic factors might play a complicated role in setting the level of sensitivity to certain kinds of events, including but not limited to the level of nerve system reactivity to tension and other challenges. Scientists know there is no single gene involved. Many genes likely play a bit part in adding to vulnerability, acting together with environmental or other factors. Though, sadness can happen in people without family histories of it also. There is considerable proof that harsh early environments, especially experiences of severe hardship like abuse or neglect in youth, can create vulnerability to later depression by modifying the sensitivity of the nervous system to stressful or threatening events. Experiences of failure, rejection, social isolation, loss of a loved one, or disappointment or frustration in achieving relationship or any other life objective usually precede an episode of sadness. For that reason, many scientists regard the negative mood state of sadness as a painful signal that basic mental needs aren't being met and that new strategies are needed. They also suggest that sadness to some degree results from an absence of abilities in processing negative feelings. Some of the most effective treatments for sadness teach what can be considered fundamental mental hygiene, cognitive and emotional tools for handling negative emotions. Trauma, which can overwhelm emotional processing systems, is another typical trigger for depressive episodes. Depression in women. Females experience depression about 2 times much as men. Biological, life process, hormonal, and other factors, including experiential ones, special to women may be linked to their higher depression rate. Researchers have shown that hormonal agents directly influence brain areas that influence emotions and state of mind, and they are further checking out how hormonal agent cycles can trigger depressive states. Some women may be prone to the serious form of premenstrual syndrome called premenstrual dysphoric disorder, PMDD. Ladies are also vulnerable to depression after giving birth, when hormone and physical changes, together with the new responsibility of taking care of a helpless baby, can be frustrating. Most women also uniquely face such tested persistent stresses as balancing work and home obligations, single being a parent, domestic abuse, and caring for children and aging parents. Ongoing research probes why some people faced with huge challenges develop depression, while others with similar difficulties do not. Sadness in men. Countless men in the U.S. and everywhere in the world also suffer the psychic pain of depression. Research and clinical evidence establish that while both women and men can develop the basic signs of depression, they typically experience sadness differently and might have different ways of dealing with the signs. Men might be more happy to acknowledge tiredness, irritability, loss of interest in work or hobbies, and sleep disturbances, instead of feelings of sadness, insignificance, and extreme guilt. Some scientists question whether the standard definition of depression and the diagnostic tests based upon it effectively capture the condition as it occurs in men. Depression can also influence the physical health in guys in a different way from women. One study shows that, though depression is connected with an increased risk of coronary cardiovascular disease in both males and females, only men experience a raised death rate. Instead of acknowledging their emotions or looking for help in the form of proper treatment, guys might turn to alcohol or drugs when they are distressed. They may also be mad, irritable, and sometimes violently violent. Some men handle psychological distress by throwing themselves compulsively into their work, trying to hide their sadness from themselves, family, and friends. Other guys may respond to depression by taking part in negligent conduct, taking threats, and putting themselves in damage's way. More than 4 times as many guys as women die by suicide in the U.S., though women make more suicide attempts during their lives. In light of the research suggesting that suicide is usually related to sadness, the high suicide rate among guys might show the fact that many men with depression do not seek appropriate diagnosis and treatment. Encouragement and support from concerned family members can be life-saving. In the office, worker assistance programs or worksite psychological health programs can be particularly crucial in helping men understand sadness as a real disorder that needs treatment. Sadness in the elderly. Contrary to some popular thinking, depression isn't a typical accompaniment to aging. On the contrary, older people tend to experience rising up levels of fulfillment with their lives. Even so, when older grown-ups do develop depression, the condition might be neglected because it can manifest less in emotions of sadness or sorrow, and more in irritability or general apathy or feelings of exhaustion. Also, depression tends to affect memory, and in the senior depression can show up as confusion or problems with attention. Aging brings many life changes that can be triggers for sadness, which includes loss of a loved one, loss of employment and sense of purpose, loss of effectiveness or good health. In addition, medical conditions that happen more regularly with age, such as heart disease, stroke, and cancer, may cause depressive signs. or the medications used for such conditions might carry side effects that contribute to sadness. There is a type of depression that develops in late life, called vascular depression. In some cases, also called arteriosclerotic sadness or subcortical ischemic sadness. It arises from cerebrovascular damage that occurs with heart disease. Brain imaging studies show that parts of blood vessel damage limit blood flow to areas of the brain involved in feeling and state of mind regulation, or to the brain's white matter. People who develop vascular sadness typically have a history of high blood pressure or hypertension. Vascular sadness might manifest in fear, aggressive tendencies, or lethargy and slowing down of movement. There are deficits in executive function. Analysis may include magnetic resonance imaging, MRI, to detect vascular pathology in specific parts of the brain. Vascular depression tends not to respond to antidepressant medication. Instead, the first line of method might be forms of psychosocial support and/or cognitive behavior therapy. The majority of older adults with sadness enhance when they receive treatment with psychiatric therapy, antidepressant medication, or a mix of the two. Research has shown that psychotherapy alone can be effective in prolonging periods free of depression. Treatment. Sadness, even in the most extreme cases, is an extremely curable disorder. The quicker treatment begins, the more effective it is and the greater the possibility that reoccurrence can be prevented. Appropriate treatment for depression starts with a health examination by a physician. Certain medications, and also some health conditions, including viral infections and thyroid disorder, can trigger depression-like symptoms and should be eliminated. Once a physical cause of sadness is dismissed, a psychological examination can be carried out, either by the examining doctor or through referral to a mental health expert. An assessment ought to include an in-depth inquiry into the history and nature of present signs and previous episodes, and their management, as well as any family history of sadness and its treatment. From this information, the severity of existing symptoms can be ranked. This information works as a standard for measuring enhancement over time and guides the course of treatment. Once diagnosed, sadness can be treated with psychiatric therapy, medication, or a mix of both. Medication might help reduce symptoms while psychiatric therapy addresses the negative thoughts, feelings, and beliefs that give rise to distress and that need to be managed in more productive ways. Psychiatric therapies. For moderate to moderate sadness, psychiatric therapy is normally considered the best treatment alternative. Psychiatric therapy is necessary in helping clients develop strategies for handling the circumstances that trigger sadness and to efficiently manage the negative ideas and emotions that mark the distress. Both cognitive behavioral therapy, CBT, and interpersonal treatment, IPT, have been widely tested and revealed to be efficient in treating depression. By teaching new ways of thinking and behaving, CBT gives people abilities to deactivate negative styles of thinking and acting. IPT helps people comprehend and work through bothered personal relationships that may cause or intensify their sadness. Research studies have suggested that for adolescents, a combination of medication and psychiatric therapy may be the most effective method to dealing with significant depression and lowering the probability for recurrence. Likewise, a research study taking a look at sadness treatment among older adults found that clients who reacted to initial treatment of medication and IPT were less likely to have repeating sadness if they continued their combination treatment for at least 2 years. Medications. Antidepressants target different neurochemicals, significantly serotonin, norepinephrine, and dopamine, known to be involved in the relay of signals through numerous brain circuits. Nonetheless, it isn't totally clear how they work or why they can take weeks or months to produce a favorable effect. The brain is an extremely complex organ. The most popular medications are called selective serotonin reuptake inhibitors, SSRIs. SSRIs include fluoxetine, Prozac, citalopram, Celexa, and sertraline, Zoloft, to name a few. Serotonin and norepinephrine reuptake inhibitors, SNRIs, are comparable to SSRIs and include venlafaxine, Effexor, and duloxetine, Cymbalta. Now in use for decades, SSRIs and SNRIs coexist with older classes of antidepressants, tricyclics, named for their chemical structure, and monoamine oxidase inhibitors, MAOIs. The SSRIs and SNRIs tend to have fewer significant adverse effects than the older drugs. Still, medications impact everyone differently, and there's no one-size-fits-all medication. Tricyclics and MAOIs stay essential antidepressants. Finding a medication program that works for any particular patient may take trials of more than one antidepressant and more than one kind of antidepressant. Antidepressants generally require time to work. Patients should take regular dosages for at least 3 to 4 weeks before they're likely to experience a full healing effect, and continue taking the medication to maintain improved mood and to stop a relapse of the depression. Though antidepressants aren't habit-forming or addictive, quickly ending an antidepressant treatment can trigger withdrawal symptoms or lead to a regression. Some individuals, such as the ones with persistent or recurrent sadness, may need to remain on the medication indefinitely. Despite the relative security and popularity of SSRIs and other antidepressants, some research studies have suggested that they might have unintentional results on some people, specifically adolescents and young adults. The United States FDA requires a black box warning label on all antidepressant medications to alert the general public about the potential increased risk of self-destructive thinking or attempts in children, adolescents, and young people taking antidepressants. Adverse effects can restrict the usefulness of SSRIs, SNRIs, tricyclics, and MAO inhibitors. Many people taking MAOIs should follow substantial food and medical limitations, from white wine and cheese to decongestants, to stay away from potentially serious interactions. Clients taking an MAO inhibitor should get a total list of restricted foods, medications, and substances at the time of prescription. The most common negative effects of tricyclic antidepressants include dry mouth, irregularity, trouble emptying the bladder, sexual problems, blurred vision, lightheadedness, and daytime sleepiness. The most common negative effects connected with SSRIs and SNRIs include headache, queasiness, anxiousness and insomnia, agitation, and decreased sexual desire. The latest medication in the antidepressant toolbox is ketamine, an agent long used securely as an anesthetic. In randomized, controlled trials, a molecular variation of ketamine, called esketamine, has recently been found safe and reliable as a treatment for sadness. Administered by nasal spray, it acts extremely rapidly to enhance mood. Further, studies show that it also reduces suicidal thinking. It is not fully clear how esketamine produces its antidepressant results, but the drug has a system of action that is different from any other readily available antidepressant drug. It binds to NMDA receptors in the brain, obstructing uptake of the excitatory neurotransmitter glutamate, which causes a rapid boost in glutamate levels. The glutamate burst eventually strengthens neural circuits in areas of the brain associated with inspiration, memory, and mood, known to be impaired in sadness. The new drug, trade-named Spravato, is intended for grown-ups with treatment-resistant sadness, and because of its potential for abuse, is administered in medical professionals' offices. Herbal treatment. Throughout the years, there has been substantial interest in the application of herbs for the treatment of both sadness and anxiety. St. John's wort, Hypericum perforatum, often used in Europe, has excited interest in the United States too, as it has been used for centuries in many folk and natural remedies. Certain contemporary studies have tested the effectiveness of St. John's wort for depression. According to the National Center for Complementary and Integrative Health, St. John's wort isn't regularly efficient for sadness, Do not use it to change conventional care or to hold off seeing your healthcare company. Farther, St. John's wort limits the effectiveness of many prescription medications. Integrating St. John's wort and certain antidepressants can lead to a possibly dangerous boost in your body's level of serotonin, a chemical produced by nerve cells. Neurostimulation therapies. Electroconvulsive treatment, ECT, is useful, especially for people whose sadness is extreme or life-threatening, or for those that can't take antidepressant medication. ECT typically works in cases where antidepressant medications do not offer sufficient relief of signs. Over the last few years, ECT has been much improved. A muscle relaxant is given before treatment, which is done under short anesthesia. Electrodes are put at precise areas on the head to deliver electrical impulses. The stimulation causes a quick, about 30 seconds, seizure within the brain. The individual receiving ECT does not consciously experience the electrical stimulus. For full restorative advantage, at the very least, some sessions of ECT, generally given at the rate of 3 weekly, are required. Lifestyle changes. Research shows that some factors in daily living have a favorable effect on state-of-mind states. Those include a nutrient-rich diet plan, exercise, direct exposure to sunlight and outdoors, and social activity. Lifestyle changes that address these elements are significantly considered a wise course in any treatment plan. How to help yourself if you are depressed. Depressive disorders can make an individual feel tired, useless, helpless, and hopeless. Such negative thoughts and feelings make people feel like quitting. It is essential to recognize that such negative views belong to the disorder and generally do not reflect actual situations. Negative attitude fades as treatment starts to take effect. In the meantime, try to be with other people and to confide in somebody. It is generally better than being by yourself and secretive. Participate in activities that may make you feel better. Even mild exercise, going to a motion picture or a ball game, or taking part in spiritual, social, or other activities can help. Expect your mood to improve slowly. It takes time. Because sadness misshapes thinking, it is advisable to delay crucial choices until the depression lifts. Before choosing to make a considerable shift, change jobs, get married, or divorce, discuss it with others who know you well and have a more objective view of your situation. Let family and friends help you. How family and friends can help a depressed individual. The most important thing anybody can do for a depressed individual is to help her or him get a proper diagnosis and treatment. It might need making a visit on their behalf and accompanying them to the medical professional. Encourage a loved one to stay in treatment is handy. Psychological support is also indispensable. This includes understanding, patience, love, and motivation. Engage the depressed person in conversation and listen carefully. Do not disparage feelings uttered, but explain truths and offer hope. Do not disregard comments about suicide. Report them to the depressed individual's therapist. Welcome the depressed person for walks, getaways, to the films and other activities. Keep attempting. Though diversions and company are needed, too many needs might increase feelings of failure. Remind your good friend or relative that with time and treatment, the depression will lift. Chapter 6. The Brief Psychotic Disorder. A quick psychotic disorder is an unusual psychiatric condition, defined by sudden and momentary periods of psychotic conduct, like delusions, hallucinations, and confusion. Signs can endure for only 1 day, or for as long as 1 month, but may be extreme enough to put the individual at increased risk of violent behavior or suicide. A bulk of cases present for the first time when an individual is in their 20s or 30s, although start can take place at any age. Short psychotic disorder is differentiated from other disorders in which psychosis happens by its limited duration, and it is not set off by drugs or alcoholic abuse. In many cases, brief psychotic disorder doesn't suggest the presence of a persistent psychological health condition. Signs. According to the DSM-5, signs of brief psychotic disorder might include misconceptions and hallucinations, abrupt and extreme state-of-mind changes, ridiculous or disordered speech, messy behavior, catatonia. Women are more likely than men to develop quick psychotic disorder, particularly postpartum. The DSM-5 classifies one subtype of short psychotic disorder as psychosis with start within 1 month of giving birth. The majority of people who develop quick psychotic disorder experience only one episode and are able to resume all activities with no permanent symptoms or impairment. Many people with certain personality disorders have a raised risk of experiencing a short psychotic episode, as are those that have experienced injury or serious stress. It is important to comprehend that the prognosis for quick psychotic disorder is typically good. However, an initial psychotic episode may be the first indication of a persistent mental health condition like schizoaffective disorder, schizophrenia, or a state-of-mind disorder with psychotic symptoms. The diagnosis of quick psychotic disorder is usually reevaluated if signs persist for more than 1 month. Causes. The reason for short psychotic disorder is uncertain, but major tension or injury, such as the death of a loved one, attack, or natural catastrophe, can set off an episode. Similar to other conditions on the psychotic spectrum, there may be a hereditary, biologic, environmental, or neurological basis for this episode. Neurological abnormalities have been found in people with psychotic disorders. Some appear to be present before symptoms first appear, while others, irregularities, have been recorded after the onset of signs. Brief psychotic disorder tends to run in families. Treatment. Normally, a health or psychiatric specialist will speak with the person to dismiss any other physical or psychological health condition that exists concurrently or could be causing the signs. Antipsychotic medications and, if necessary, antidepressants may be recommended to help manage signs, and the individual might really need to be supervised at all times to ensure they do not harm themselves or others. Short-term psychiatric therapy can help a person understand and recuperate from brief psychotic disorder, manage their medications, and learn how to handle tension. The people who fail to look for treatment after a very first psychotic episode are more likely to see a future reoccurrence of brief psychotic disorder, or to subsequently be identified with a persistent disorder on the psychotic spectrum. Chapter 7. Postpartum Disorder. Because of remarkable hormonal changes related to pregnancy and giving birth, some new mothers experience the onset of a depressive episode. While mild depression or the baby blues are really common and might also reflect the living style changes accompanying new maternity, roughly 3 to 6% of women experience the beginning of a major depressive episode in the weeks or months following delivery. The episode is often accompanied by serious anxiety and even panic attacks. In rare cases, the sadness may be accompanied by such psychotic features as misconceptions and hallucinations. Professionals find that completely half of depressive episodes considered postpartum actually have their beginning before delivery, referred to as sadness with peripartum start. Studies show that women who experience mood and anxiety signs during pregnancy are at increased risk for developing a postpartum major depressive episodes. Signs. The mildest and most typical form of postpartum depression is referred to as the child blues. Symptoms emerge spontaneously throughout the first 10 days after childbirth and tend to peak around 3 to 5 days. Although symptoms are distressing, they usually decrease within 24 to 72 hours. Typical signs include anxiety, sadness, irritability, confusion, sobbing spells, sleep and cravings disruptions, and lack of feeling for the child. Postpartum sadness can take place anytime within the first year after childbirth, generally within 4 weeks after delivery, but in some cases, some months later. Symptoms should exist for at least 2 weeks and must affect the mother's capability to function. Most patients experience symptoms 6 months after onset. Events that predispose a woman to postpartum sadness include previous postpartum sadness. One incidence may increase the risk of reoccurrence by up to 70%. Depression unrelated to pregnancy. A previous episode may increase the risk by 30%. Serious premenstrual syndrome. Stressful marital, family, vocational, or monetary conditions. Undesirable pregnancy or uncertainty about the pregnancy. Symptoms reported for postpartum sadness include depressed mood for the majority of the day and nearly every day, loss of interest in activities previously considered enjoyable, despondence and despair, thoughts of suicide and/or infanticide, fear of damaging the child, lack of concern or over-concern for the infant, emotions of guilt, inadequacy, and insignificance, poor focus and impaired memory, strange ideas, hallucinations, terrible nightmares, panic or anxiety attacks, agitation or sleepiness. Postpartum psychosis takes place at a rate of 1 to 2 out of each 1,000 deliveries. Symptoms generally happen within the first 4 weeks following delivery, but can manifest any time up to 90 days after delivery. It is identified by a quick and serious start. Women with this disorder are severely impaired and struggle with deceptions and hallucinations, sometimes with command hallucinations to kill the baby or delusions that the infant is possessed and are in danger for suicide and/or infanticide. Causes. While biological, psychosocial, and cultural aspects impact the condition, the exact causes of postpartum depression are unknown. Hormonal agent levels change significantly throughout pregnancy, delivery, and the postpartum period. Researchers are examining a possible relationship between abrupt shifts in hormone levels and postpartum depression. Postpartum dysregulation of the thyroid gland may contribute. The thyroid gland regulates some hormones and production drops drastically after birth, going back to typical functioning over a period of months. Thyroid changes may add to the feelings of fatigue that new mothers typically experience. Social and mental factors can also contribute to the beginning of a postpartum disorder. New moms need high levels of support in their new role, and extended postpartum sadness is connected to lack of social support. New mothers need not only emotional support, but home support, including aid with home chores and childcare. Such support might be lacking for a single mom or for a woman with few members of the family close by. Sleeplessness or tiredness are really common complaints following childbirth. Delivering taxes a woman's strength, and it can take several weeks to recuperate. A cesarean delivery is significant surgical treatment and needs even more recovery time. Integrated with the energy spent looking after a child around the clock and tending to other obligations, new mothers practically invariably experience insufficient rest. The resulting fatigue may increase a woman's vulnerability and act as an added risk for depression. The mother's changing role may feed feelings of inadequacy. A woman's mindset towards her pregnancy might affect risk for peripartum or postpartum sadness. It is common for a woman to feel doubt about pregnancy, especially when unintended. A higher incidence of depression is reported among women who are ambivalent about pregnancy. Early loss of one's own mom or a bad mother-daughter relationship may trigger a woman to feel unsure about her new baby. She may fear that looking after the child will result in pain, dissatisfaction, or loss. Weight gain throughout pregnancy can also affect self-esteem and increase the risk of depression, as can breastfeeding problems. Females who have their children by cesarean birth are likely to feel more depressed and have lower self-confidence than women who had spontaneous vaginal deliveries. Moms with preterm infants typically become depressed. An early birth leads to unanticipated changes in routine and is an added stressor. A baby with a birth defect makes change a lot more hard for parents or caretakers. The length of time the mom spends in the health center may be related to her emotional wellness. There's proof that early discharge increases the risk of developing sadness. The birth of a very first child is a particularly demanding event for new mothers, and appears to have a greater relationship to depression than do the birth of a second or third kid. Cross-cultural studies suggest that the incidence of postpartum depression, but not psychosis, is much lower in non-Western cultures. These cultures appear to provide the new mom with a level of emotional and physical support that's mainly absent in Western society. In more conventional cultures, there's greater recognition of the demands of motherhood. Thus, the new mother gets guarantee that the discomfort she's experiencing will pass, and that she won't need to deal with those emotions alone. Treatment. Postpartum depression is treated just like other kinds of sadness. The most typical treatments for depression are psychotherapy and participation in a support system, antidepressant medication, or a combination of those treatments. The most frequently used medications to treat sadness are selective serotonin reuptake inhibitors, or SSRIs. As is the case with other medications, antidepressants can find their way into breast milk. Women who breastfeed should speak with their physicians to identify the most appropriate treatment. Many forms of psychiatric therapy, which includes some short-term, 10 to 20-week therapies, can help depressed individuals. Talk therapies can help clients get insight into and resolve their problems through verbal exchange with the therapist, at times combined with homework projects between sessions. Behavioral therapists help clients learn how to acquire more fulfillment and rewards through their own actions, and how to unlearn the behavioral patterns that contribute to or arise from their sadness. Furthermore, treatment can help an individual comprehend what triggers their symptoms and how best to deal with their distress. Chapter 8. Borderline Personality Disorder. Borderline personality disorder is a chronic condition that might include mood instability, trouble with interpersonal relationships, and high rates of self-injury and suicidal conduct. Borderline personality disorder, BPD, is identified by prevalent instability in moods, interpersonal relationships, self-image, and conduct. That instability often interferes with family and work life, long-lasting planning, and a person's sense of identity. People with BPD, originally thought to be at the border of psychosis and neurosis, struggle with problems with feeling control. While less well-known than schizophrenia or bipolar disorder, BPD impacts 2% of adults. Many people with BPD exhibit high rates of self-injurious conduct, such as cutting, and raised rates of tried and finished suicide. Problems from BPD and suicide risk are greatest in the young adult years and tend to decrease with age. BPD is more common in women than in guys, with 75% of cases identified among women. People with borderline personality disorder often really need comprehensive mental health services and account for 20% of psychiatric hospitalizations. Yet, with help, the bulk stabilize and lead productive lives. Signs. According to the DSM-5, people with BPD show some or all of the following symptoms: efforts to avoid real or imagined desertion, intense bouts of anger, sadness, or anxiety that may last only hours or at most several days. Those might be associated with episodes of impulsive hostility, self-injury, and drug or alcoholic abuse. Distortions in ideas or sense of self can lead to regular changes in long-term goals, profession plans, jobs, friendships, identity, and values. At times, people with BPD view themselves as essentially bad or not worthy. They may feel bored, empty, or unfairly misconstrued or maltreated, and they have little idea who they are. Reoccurring suicidal conduct. Transient, stress-related paranoid thinking or dissociation, losing touch with reality. People with BPD typically have highly unsteady patterns of social relationships. While they can develop intense but rainy attachments, their mindsets toward family, good friends, and loved ones might suddenly move from idealization, great appreciation and love, to devaluation, intense anger and dislike. Thus, they might form an immediate attachment and idealize another individual, but when a minor separation or dispute takes place, switch unexpectedly to the other severe and angrily implicate the other individual of not caring for them at all. The majority of people can tolerate the uncertainty of experiencing two contradictory states at one time. Most people with BPD, though, should shift backward and forward between good and bad states. If they are in a bad state, for example, they have no awareness of the good state. People with BPD are highly susceptible to rejection, reacting with anger and distress to mild separations. Even a holiday, a firm trip, or an unexpected change in strategies can spur negative ideas. These fears of desertion appear to be related to difficulties feeling mentally connected to important people when they are physically missing, leaving the individual with BPD feeling lost or useless. Suicide threats and attempts might take place along with anger at perceived abandonment and dissatisfactions. Causes. Although the cause of BPD is unknown, both ecological and hereditary aspects are thought to play a role in inclining people to BPD. The disorder is approximately 5 times more common among people with close biological family members with BPD. Studies show that many individuals with BPD report a history of abuse, overlook, or separation as children. 40 to 71% of BPD clients report having actually been sexually mistreated, normally by a non-caregiver. Researchers believe that BPD arises from a combination of individual vulnerability to environmental stress, neglect, or abuse as young kids, and a series of events that trigger the onset of the disorder as young adults. Adults with BPD are also substantially more likely to be the victims of violence, which includes rape and other criminal offenses. These events might arise from damaging environments and the victim's impulsivity and poor judgment in choosing partners and way of lives. Neuroscience is exposing brain mechanisms underlying the impulsivity, mood instability, aggressiveness, anger, and negative emotion seen in BPD. Studies suggest that people predisposed to spontaneous aggression have impaired regulation of the neural circuits that regulate emotion. The brain's amygdala, a small almond-shaped structure, is a crucial part of the circuit that manages negative emotion. In reaction to signals from other brain centers showing a perceived risk, it marshals fear and stimulation, which might be more noticeable under the influence of tension or drugs, like alcohol. Areas in the front of the brain, in the prefrontal cortex, act to dampen the activity of this circuit. Current brain imaging research studies show that individual differences in the capability to activate regions of the prefrontal cortex thought to be involved in repressive activity anticipate the ability to suppress negative emotion. Serotonin, norepinephrine, and acetylcholine are amongst the chemical messengers in these circuits that contribute in the regulation of emotions, including but not limited to sadness, anger, anxiety, and irritability. Drugs that boost brain serotonin function may enhance psychological symptoms in BPD. Also, mood-stabilizing drugs that are known to boost the activity of GABA, the brain's significant inhibitory neurotransmitter, might help people who experience BPD-like mood swings. Such brain-based weaknesses can be managed with help from behavioral interventions and medications, much as people manage susceptibility to diabetes or hypertension. Treatment. The advised treatment for BPD includes psychiatric therapy, medication, and group, peer, and family support. Group and individual psychotherapy have been shown to be effective forms of treatment for many patients. Psychotherapy is the first-line treatment for BPD, and several forms of therapy, like dialectical behavioral therapy, DBT, mentalization-based treatment, MBT, cognitive behavior therapy, CBT, and psychodynamic psychiatric therapy have been studied and shown to be reliable ways to ease symptoms. Pharmacological treatments are typically recommended based on specific target signs shown by the individual patient. Antidepressant drugs and state-of-mind stabilizers may be useful for depressed and/or labile state of mind. Antipsychotic drugs may also be used when there are distortions in thinking. This has been Personality Disorders: The Intricacy of Schizoid and Depressive Disorders, written by Derek Halfson, narrated by Rory Young. Personality Disorders: A New Perspective on Bipolar Disorder and Narcissism, written by Derek Halfson, narrated by Rory Young. Chapter 1. Bipolar Disorder. Bipolar disorder, or manic depressive disease, is a group of conditions characterized by the presence of noticeable, high-energy phases, referred to as manic episodes. Typically, unusual shifts in state of mind and energy manifest in increased activity levels and impair capability to work. The problems created by bipolar disorder can be serious and can lead to harmed relationships, poor job or school efficiency, and even suicide. There are some different kinds of bipolar illness. Bipolar I disorder refers to a condition in which an individual experiences a full-blown manic episode for at the very least 1 week, and might or might not also experience sadness. The manic signs might be so extreme that hospitalization is needed. Bipolar II refers to the presence of a current or past hypomanic episode, which is a slightly less serious form of mania lasting at the very least 4 successive days, and also the presence of an existing or past episode of significant depression. Cyclothymic disorder, or cyclothymia, refers to recurring hypomanic and depressive mood shifts over at least a 2-year period in grown-ups. According to the National Institute of Mental Health, an approximated 4.4% of grown-ups in the United States experience a bipolar affective disorder at some time in their lifetime. The condition accompanies equal frequency among males and women. The typical age of beginning is 25 years. However, a bipolar disorder might start in youth or may have its beginnings late in life. Bipolar disorders are normally chronic conditions and require long-lasting management. More than 90% of people who have a single manic episode go on to have recurrent episodes of mania or sadness. People experiencing a manic episode are typically referred to as excessively pleasant or feeling on top of the world. Frequently, however, the dominant state of mind throughout a manic episode is irritation. In addition, individuals experiencing mania may display all of a sudden inflated self-esteem, reduced need for sleep, talkativeness, and distractibility, and typically take part in activities that have high potential for unpleasant consequences: betting, heavy spending, sexual indiscretions. Hypomania resembles mania in that the disturbance in mood and the change in functioning are visible by others, but the episode is not severe enough to cause significant disability in social or occupational functioning, or to require hospitalization. During a manic episode, someone may start multiple new projects and feel that they are very capable of achieving anything, regardless of their level of experience or talent. One of the most typical features of mania is a decreased need for sleep. A person might go days without sleep, yet not feel worn out. Typically, a manic person's ideas race much faster than they can be uttered. The result may be abrupt shifts in topic and pressured and incoherent speech. At times, throughout a manic episode, people display animosity and upset tirades, especially if an attempt is made to interrupt them. Kids who are in danger of bipolar illness, just because a parent or caretaker has the disorder, display a developing sequence, beginning with signs that are not particular to bipolar disorder, notably sleep issues and anxiety. The condition advances from small mood disorder to significant depressive disorder in teenage years, with full-blown bipolar disorder developing in the transition to their adult years, typically with an episode of mania or hypomania, or a very first episode of psychosis following an episode of depression. It is characteristic of the condition that those who are experiencing mania don't perceive that they are ill or in need of treatment and resist engaging with treatment. Diagnosis and treatment are exceptionally crucial. The lifetime risk of suicide among people with bipolar disorder is at least 15 times that of the general population. Bipolar illness is often not recognized or may be interchanged with other conditions, and people may suffer for many years before they receive proper treatment. Symptoms. According to the DSM-5, a manic episode appears in an exceedingly blissful, extensive, or irritable mood for most of a day, every day, for at the very least a week, and is joined by unusually and persistently increased activity and energy. Moreover, 3 or 4, if the dominant state of mind is irritability, of the following signs must be present: inflated self-esteem or grandiosity, including but not limited to unrealistic beliefs in an individual's abilities and powers; decreased need for sleep; uncommon talkativeness or pressure to keep talking; flight of ideas or the sense that thoughts are racing; distractibility; increased goal-directed activity like work or school projects, or purposeless activity; psychomotor agitation; involvement in activities that are very likely to have unpleasant repercussions, like purchasing sprees, sexual indiscretions, poor business financial investments. In addition, the state of mind disruption suffices to trigger significant impairment in social or occupational functioning, or to require hospitalization to stop self-harm, or just because there are psychotic features. What's more, the episode is not explainable by consumption of a medication, drug of abuse, or medical condition. The more moderate form of mania, called hypomania, likewise involves an unquestionable change in functioning, though for 4 or more days, but there's generally not significant social or occupational impairment. Indeed, the person might feel good and highly productive, making it difficult for the person or those around him or her to determine a hypomanic episode. Bipolar disorders are normally marked by the event of, at the very least, one depressive episode. A depressive episode is characterized by depressed state of mind, or loss of enjoyment or interest, or emotions of hopelessness for at the very least 2 weeks. According to the DSM-5, at the very least 5 of the following symptoms are also present. The miserable, restless, or empty mood exists most of the day, each day. Loss of interest or satisfaction in all or most activities is present the majority of the day, every day. Unintended weight gain or loss. Insomnia or excessive sleep. Observable uneasiness, psychomotor agitation, or slowing down, psychomotor retardation. Fatigue of less of energy almost each day. Feelings of guilt or worthlessness. Reduced ability to concentrate or indecisiveness. Recurrent thoughts of death or suicide efforts. The signs cause distress or impairment in functioning, and they are not due to the impacts of a compound or health condition. In certain cases, severe episodes of mania or depression include signs of psychosis. Common psychotic signs are hallucinations, hearing, seeing, or otherwise sensing the presence of things not actually there, and deceptions, false, highly held beliefs not influenced by rational thinking or explained by an individual's normal cultural ideas. Psychotic symptoms in bipolar disorder tend to reflect the severe state of mind state at the time. For instance, misconceptions of grandiosity, such as believing one is the president or has special powers or wealth, might happen during mania. Delusions of guilt or insignificance, like believing that one is destroyed and poverty-stricken, or has committed some horrible criminal activity, might appear during depression. For this reason, bipolar illness is sometimes incorrectly detected as schizophrenia. In some people, though, symptoms of mania and depression may happen together in what's called bipolar disorder with mixed features. Symptoms of mixed functions typically include agitation, trouble sleeping, substantial change in hunger, psychosis, and suicidal thinking. An individual might have a really sad, helpless mood, while at the exact same time feeling extremely energized. Some people with bipolar illness become self-destructive. Anyone who is thinking about committing suicide needs instant attention from a health specialist. Discuss suicide should be taken seriously. Threat for suicide seems to be higher early in the course of the disease. Recognizing bipolar disorder early and learning how best to manage it may decrease the risk of death by suicide. Episodes of mania and depression usually recur across the lifespan. Between episodes, many people with a bipolar affective disorder are free of symptoms, but as many as 1/3 have some recurring signs. A small portion experience persistent continuous signs in spite of treatment. When 4 or more episodes of health problem take place within a 12-month period, a person is said to have rapid cycling bipolar illness. Many people experience multiple episodes within a single week, or perhaps within a single day. Quick biking tends to develop later in the course of disease and is more typical amongst women than men. People with bipolar disorder can lead healthy and efficient lives when the health problem is effectively dealt with. Without treatment, however, state-of-mind biking can increase in frequency and seriousness. Both children and teenagers can develop bipolar disorder. The condition is most likely to affect the children of parents who have the health problem. Kids and young adolescents often experience very fast mood swings between sadness and mania several times a day. Mania in kids is probably to manifest as irritation with proneness to destructive tantrums. The occurrence of combined signs is also common in youth with bipolar affective disorder. Older adolescents who develop the illness might have more traditional, adult-type episodes and signs. Bipolar affective disorder in children and adolescents can be hard to distinguish from other problems that may happen in these age. Irritability and aggressiveness can also be signs of attention deficit hyperactivity disorder, perform disorder, oppositional bold disorder. Alcohol and substance abuse are really common amongst people with bipolar illness. Many factors might add to the substance abuse issues, including self-medication of symptoms. Nevertheless, mood symptoms can be caused or perpetuated by substance abuse. There might exist risk aspects that impact the occurrence of both bipolar affective disorder and substance use conditions. Co-occurring drug abuse, when present, is a fundamental part of a general treatment strategy. Anxiety disorders, like panic attacks and social anxiety disorder, might also co-occur in people with bipolar affective disorder, and they may react to treatments used for bipolar affective disorder, or they may require separate treatment. Causes. The cause of bipolar disorder is the subject of much research, and the agreement among scientists is that there's no single cause. Rather, many elements act together to produce the illness. Genetics play a role. One of the strongest risk factors for developing bipolar illness is having a family history of the health problem. Danger of the condition is increased tenfold amongst adult relatives of people with bipolar I and bipolar II disorders. Nonetheless, no specific genes have been connected to the condition. Rather, as with many other mental illnesses, multiple genes, each with a little effect, add to the possibility of developing the disorder. There is some proof that mood, anxiety, and psychotic conditions accompany greater frequency in the families of the ones with bipolar illness than in the general population. Studies of twins who share all of the same genes show that factors besides genes, such as highly stressful events, also contribute in precipitating bipolar illness. Most genes likely act together in combination with consider a person's environment. Brain imaging research studies show that the brains of people with bipolar illness may vary from those of healthy individuals. For instance, scientists have identified some brain regions marked by reduced thickness of the cortex. Other research studies show that processing of sensory stimuli is impaired throughout episodes of mania and depression and may underlie mistakes in perception. Treatment. Even in the most extreme cases, bipolar illness are highly fixable conditions. The quicker treatment begins, the greater the likelihood of lowering the seriousness and frequency of manic and depressive episodes. Because bipolar disorders are lifelong conditions, treatment is also lifelong and aimed not just at treating signs, but also at stopping recurrence of signs. Most people with bipolar disorders can attain significant stabilization of their mood swings and associated signs. The most reliable treatment method integrates medication and psychotherapy. Additionally, clients are usually instructed to keep a chart of everyday state of mind signs, treatments, sleep patterns, and life events. Such tracking has been revealed to help clients and their families to better understand and manage the illness. Mood changes can usually be spotted in time to stop a full-blown episode. Even when there are no breaks in treatment, mood changes can take place and should be reported immediately to the doctor, who may make changes to the treatment plan. Medications. While primary care physicians who do not focus on psychiatry might prescribe psychotropic medications, it is suggested that people with bipolar affective disorder see a psychiatrist for treatment. Several kinds of medication are typically used to treat bipolar illness. State of mind stabilizers are typically recommended to manage manic episodes. Lithium is maybe the best known mood stabilizer. The first mood stabilizing medication authorized by the United States FDA for treatment of mania. It is typically really reliable in controlling mania and stopping the reoccurrence of both manic and depressive episodes. Other types of state of mind stabilizer include the anticonvulsants lamotrigine, Lamictal, valproic acid, Depakine, divalproic salt, Depakote, and carbamazepine, Tegretol, and others. Valproate was FDA approved in 1995 for treatment of mania. Anticonvulsant medications might be combined with lithium or with each other for maximum impact. Other medications are added when needed, usually for shorter periods, to treat episodes of mania or depression. Sometimes treatment with antidepressants leads to mood switching, prompting a manic or hypomanic episode or fast cycling. Mood-stabilizing medications generally are needed, alone or in mix with antidepressants, to protect against such a switch. Children and teenagers with bipolar disorder generally are treated with lithium, but valproate and carbamazepine are also used. Females with bipolar affective disorder who wish to conceive or who conceive face unique obstacles as a result of possible impacts of state of mind, supporting medications on the developing fetus and the nursing infant. A skilled clinician can help such women weigh the advantages and threats of all available treatment alternatives. Antipsychotic medications are also typically used to help control manic and depressive signs in bipolar disorder, and some help to support state of mind also. Antipsychotic drugs include olanzapine, Zyprexa, quetiapine, Seroquel, and risperidone, Risperdal, among others. If sleeping disorders is a problem, a high-potency benzodiazepine medication, such as clonazepam or lorazepam, may be useful. Having said that, because these medications may be habit-forming, they're best recommended short-term. Other types of sedative medications, such as zolpidem, are in some cases used instead. Omega-3 fatty acids found in fish oil are under research study for their effectiveness, alone or when contributed to traditional medications, for long-lasting treatment of bipolar disorder. Reliable management of bipolar illness may involve changes to the treatment plan at various times throughout illness. Any changes in type or dosage of medication should be made under the assistance of a psychiatrist. To avoid unfavorable responses, clients should tell the psychiatrist about all other prescription drugs, over-the-counter medications, or natural supplements they may be taking. Individuals with bipolar illness, particularly those rapid state-of-mind cycling, often have abnormal thyroid gland function. Simply because too much or insufficient thyroid hormone alone can result in state of mind and energy changes, thyroid levels are usually thoroughly kept track of by a doctor. Lithium treatment may cause low thyroid levels in some people, resulting in the need for thyroid supplementation. All medications have side effects. Depending on the medication, adverse effects might include weight gain, nausea, tremors, reduced sexual desire, anxiety, loss of hair, movement issues, or dry mouth. Getting the right balance of treatment advantages might need physician-monitored change in dosage or type of medication. Medication must not be changed or stopped without the psychiatrist's guidance. Psychiatric therapy. Studies have documented that several sorts of psychiatric therapy provided to clients and their families can result in increased state-of-mind stability, fewer hospitalizations, and enhanced functioning in some areas. Psychotherapeutic interventions commonly used for bipolar illness are cognitive behavior therapy, psychoeducation, family therapy, and social rhythm treatment, IPSRT. IPSRT stresses the importance of establishing steady daily patterns of sleeping and waking, as extended wakefulness is a recognized trigger for manic episodes. A certified psychologist, social worker, or counselor typically offers such therapies and often operates in show with the psychiatrist to keep an eye on patient development. Cognitive behavior therapy, CBT, helps people with bipolar illness learn to change inappropriate or negative thought patterns and behaviors associated with the health problem. Psychoeducation includes teaching people with bipolar illness about the condition and its treatment, and how to recognize signs of relapse so that early intervention can be looked for before a full-blown episode occurs. Psychoeducation is also often practical for relatives. Family therapy helps reduce the level of family distress that may add to or arise from the ill individual's symptoms. Interpersonal and social rhythm treatment help people with bipolar disorder, both to enhance relationships and to control day-to-day regimens. Keeping an everyday regimen and sleep schedule can help protect against manic episodes. Electroconvulsive treatment. In certain circumstances, such as psychosis or self-destructive thought, where medication, psychosocial treatment, and the mix of these interventions prove ineffective or work too slowly to relieve serious signs, electroconvulsive treatment, ECT, may be considered. ECT may also be considered to deal with intense episodes when medical conditions, including pregnancy, make the application of medications too risky. ECT is a highly effective treatment for extreme depressive, manic, or combined episodes. The possibility of long-lasting memory problems has been considerably decreased with modern-day ECT strategies. Chapter 2. Narcissism. Narcissism. Narcissists have a popular place in the popular imagination, and the label narcissist is commonly released to describe people who appear too content with themselves. There's also a growing sense that narcissism is on the rise around the world, particularly amongst youths, though most mental research doesn't support that notion. Narcissism is properly seen on a spectrum. The quality is typically distributed in the population, with the majority of people scoring near the middle, and several at either extreme. The Narcissistic Personality Stock, NPI, developed by Robert Raskin and Calvin S. Hall in 1979, is the most commonly used procedure of the trait. Scores range from 0 to 40, with the average tending to fall in the low to mid-teens. Healthy people who score somewhat higher may be perceived as exceptionally charming, specifically on first encounter, but eventually seem as though vain. Such individuals may have awkward or difficult personal encounters, but still have a fundamentally healthy character. The qualities of narcissism. It's simple to specify someone who spends a bit too much time talking about her profession or who never appears to doubt himself as a narcissist. But the characteristic is more complex than that. Narcissism doesn't necessarily represent a surplus of self-esteem or of insecurity. More accurately, it includes a cravings for appreciation or affection, a desire to be the focal point, and an expectancy of special treatment showing perceived higher status. Interestingly, research finds many highly narcissistic people typically easily admit to unconsciousness that they're more self-indulgent. A high level of narcissism, not remarkably, can be harmful in romantic, familial, or expert relationships. How do I spot a narcissist? Narcissism is identified by a grand sense of self-importance, an absence of empathy for others, a real need for extreme affection, and the belief that one is unique and deserving of special treatment. If you encounter someone who regularly exhibits these habits, you might be dealing with an extremely conceited person. What's the distinction between narcissism and pathological narcissism? Pathological narcissism, or narcissistic personality disorder, is rare. It influences an approximated 1% of the population, a frequency that has not changed since physicians started measuring it. The disorder is thought when narcissistic characteristics hinder a person's day-to-day performance. That dysfunction typically triggers friction in relationships as a result of the pathological narcissist's lack of empathy. It may also manifest as antagonism, sustained by grandiosity and attention-seeking. In seeing themselves as remarkable, the pathological narcissist naturally views everybody else as inferior and may be intolerant of disagreement or questioning. If you wonder whether a person is a narcissist, it might be just best to inquire. It is generally presumed that people either do not understand that they're narcissists or deny it to keep away from a challenge to their identity. However, in research using the so-called single-item narcissism scale, people who answered affirmatively to the single question, "Are you a narcissist?" were far more very likely than others to score highly on narcissism on the 40-question narcissistic personality stock. Do narcissists know that they're narcissists? If you wonder whether a person is a narcissist, it might be best just to ask them. It's typically presumed that people either do not understand that they're narcissists or deny it to stay away from a challenge to their identity. But in research using the so-called single-item narcissism scale, people who answered agreeably to the single question, "Are you a narcissist?" were much more likely than others to score highly on narcissism on the 40-question narcissistic personality stock. Are there any benefits to being conceited? Research has found some advantages in relatively high but subclinical narcissism, such as increased mental strength, carrying out well in high-pressure situations, and higher accomplishment in school and on the job. A heightened sense of self-regard may also make an individual more motivated and assertive than others. Other research has connected narcissism to a lower occurrence of sadness. Is my boss a narcissist? A conceited boss places getting ahead over getting along, which means they're often not collaborative, conceited, and argumentative, and myopically focused on being the winner. Conceited employers take all of the credit for successes and blast the ones that do not demonstrate loyalty. Those tendencies and others suggest that you may be handling a narcissistic boss. How to deal with a narcissist. Browsing a relationship with a narcissist can be deeply discouraging and upsetting. In their quest for control and admiration, egotistical people might control and make use of others, harming their self-confidence and even aiming to alter their sense of reality. Arguing with a narcissist about their action often shows unproductive. A more effective solution is to establish limits and mentally range yourself. Recognize that you might not be able to control your emotions about a person, but you can manage how you react to them. Cutting ties with a narcissistic partner, member of the family, or boss might eventually be the best, if not the only, resolution. In that process, it's useful to review the attributes of the individual to stay away from finding oneself in similar scenarios in the future. What are the strategies to deal with a narcissist? Acknowledging your aggravation, valuing where the behavior comes from, and declining to lose your own sense of purpose when a narcissist takes spotlight are crucial methods, to name a few. Researchers who categorize narcissists are either vulnerable or grand claim that particular approaches are warranted for each type. How do I handle a conceited boss? Manage your expectations, align your successes with your bosses, draw boundaries, and don't try to argue, validate, or explain yourself. These and other techniques can help you navigate a narcissist in the work environment. Narcissism in relationships. A narcissist's desire to elicit affection and praise, specifically from potential romantic partners, often makes them charming, traits which can rapidly spark a romance. But their fundamental deficit of empathy might stop them from comprehending a partner's inner world and establishing a satisfying, long-term relationship. It's nearly impossible for people with conceited personality disorder to really fall in love and build a trusting, equal partnership. Such an individual may seek to establish stringent rules in a relationship and attempt to isolate a new partner from loved ones, to name a few troubling habits. Why so narcissists make such a good first impression? Research suggests that people might initially be drawn to narcissists because they seem to possess stronger self-confidence than they really do, a quality that people often really appreciate. Can narcissists fall in love? Narcissists might show enthusiasm and charm in the early phases of dating. However, for most narcissists, relationships are transactional. They supply positive attention and sexual fulfillment to bolster a narcissist's ego and self-confidence. The objective is to enjoy uncommitted satisfaction, and most narcissists dislike the relationship as the expectation for intimacy increases, or they feel that they have dominated the obstacle of protecting a relationship. What's the distinction between selfishness and narcissism in a relationship? Conceited personality disorder is relatively uncommon. There are many more people who are simply self-centered. The difference depends on if the person is periodically mean and self-indulgent, or whether they regularly lack empathy. Chapter 3. How Narcissists Behave Like Kids. I recently watched a good friend's 5-year-old shot to convince his mom to let him change the guidelines and watch television before doing his homework. "The homework takes so long, it's too hard," the child implored. Then, without skipping a beat, the kid said, "But if you let me watch TV first, I can get the homework done in a jiffy. It'll be easy," he said. We don't always expect children to be constant. They are learning how the world works and just attempting to get their needs met. Like children, conceited grown-ups also flex the truth. Narcissists believe, or at least act just like they actually believe, that whatever they say in each moment is the outright truth, no matter that their statements are usually entirely contradictory. But in contrast to innocent children, narcissists' disparities and manipulations have far greater repercussions to those around them. If you expect narcissists to consistently behave like responsible adults, you are very likely to be dissatisfied. When narcissists feel embarrassed, slighted, or inferior, they regularly revert to a childlike state, behaving like a kid throughout the awful twos. Such regression isn't unexpected. Narcissistic personality disorder may develop as a result of early injury or family influences that can leave a person emotionally stuck at a young age. Adult narcissists use advanced versions of childlike responses. When seen in this light, the typically mystifying and infuriating actions of narcissists start to make sense. For instance, a child caught with his hand in the cookie container after being told to wait till after dinner will react in one or more of a baker's lots of predictable ways as follows. Blame someone else. But I did not know you were watching, so it's not my fault. Say they had no choice. But I was starving. Pretend they don't know what you are talking about. What cookies? Recite good ideas they have done, but I looked at them for a really very long time before taking one. Cry or act just like a victim. I always get caught. It's not fair. Deny they did anything wrong. I was just searching for later. I wasn't going to eat it now. Get mad at you. You're a mean mommy. Change the subject. Can I go play now? Try to charm you. But I love you so much, mommy. Lesson. But I do not even like that kind of cookie. Hide or run away. Overlook you. Throw a temper tantrum. In examining the previous examples, do any seem similar to how a narcissist you know responds when feeling stressed, slighted, or thwarted? Dealing with narcissists can be maddening. The next time you feel mystified or on the defensive by a narcissist's conduct, picture him or her as a 2-year-old in an adult body. They are seeking to avoid blame and embarrassment. Of course, adult narcissists have more power than kids. Given that, you have to choose your reactions carefully. Here are some techniques that can help. Give them choices. If you take your kid to a crowded dining establishment when you are in a rush, you give the child choices. Rather than asking what they want to eat, you say, "Do you really want mac and cheese or a PBJ?" Similarly, suggesting options to an acting-out narcissist may let them feel in control. Do not customize their behavior. You do not take a child's pouting personally. They are in the throes of emotion they haven't yet learned to contain. Most kids learn to self-soothe with time. Narcissists, though, can't self-soothe. Their feelings when they are ashamed or disappointed overwhelm them, and they will act out those emotions. Expecting adult conduct from a 2-year-old, of any age, will just leave you disappointed. Recognize the alternative truths of narcissists. Like my friend's 5-year-old I mentioned at the beginning of this post, narcissists change facts to suit them. Narcissists dwell in alternative realities constructed out of their sense of entitlement, absence of empathy, and drive to get what they really want at any cost. These childlike responses bear an astonishing resemblance to the strategies narcissists use to stay away from responsibility and manipulate others. Blaming, making excuses, pretending, looking for credit, playing the victim, rejecting, attacking, sidetracking, charming, decreasing, withdrawing, stonewalling, acting out. Recognize the alternative truths of narcissists. Like my friend's 5-year-old I discussed at the start of this post, narcissists change facts to suit them. Narcissists stay in alternative truths constructed out of their sense of entitlement, lack of empathy, and drive to get what they want at any cost. Such inconsistent conduct needs to be acknowledged for what it is, a childlike fantasy world technique to manipulating others. Chapter 4. Who are the real narcissists? Last winter, a good friend told me she was thinking about a divorce. "I really think that my spouse is a narcissist," she said. More just recently, over brunch, an acquaintance clarified his family dynamics. "My auntie is such a narcissist, we are not sure why my uncle is with her." The term narcissist has been widely released to describe not only a passel of difficult loved ones and regretted exes, but also both nominees for president and the entire generation called millennials. Is narcissism truly so extensive or on the rise in the general population? A growing consensus among psychologists says no, it isn't. True pathological narcissism has always been unusual and remains so. It influences an approximated 1% of the population, and that prevalence has not changed demonstrably since clinicians began measuring it. Most, but not all, putative narcissists today are innocent victims of a tired label. They are normal people with healthy egos who may also happen to enjoy the arbitrary selfie and talk about their achievements. They might even be a bit vain. However, while we're identifying friends, loved ones, and our kids' schoolmates, true pathological narcissists may be evading detection, just because most of us do not understand the many forms the condition may take. What narcissism is. Narcissism is a quality each of us exhibits to a higher or lower degree. As it has become trait non grata, though, it's become necessary to include the qualifier healthy to define the socially acceptable type of narcissism. It is the capacity to see ourselves and others through rose-colored glasses, says psychologist Craig Malkin, a speaker at Harvard Medical School and the author of Reconsidering Narcissism. That can be helpful, just because it's helpful for all of us to feel a bit unique. It fuels the confidence that enables us to take the risks, like looking for a promotion or asking out an attractive stranger. However, feeling too unique can trigger problems. The Narcissistic Personality Inventory is the most commonly used procedure of the trait. Developed by Robert Raskin and Calvin S. Hall in 1979, it asks an individual to choose between pairs of declarations that examine levels of modesty, assertiveness, inclination to lead, and determination to manipulate others. Scores vary from 0 to 40, with the typical tending to fall in the low to mid-teens, depending on the group being tested. The people whose rating is a standard discrepancy above that of their peers could fairly be called narcissists, but a score everywhere along a wide range of the scale may still indicate a basically healthy character. A medical diagnosis of pathological narcissism, which is a mental health disorder, involves different criteria. Egotistical personality disorder is an extreme manifestation of the trait, says growth-related psychologist Eddie Brummelman, a fellow at Stanford University. The disorder can be detected only by a mental health professional and is believed when a person's narcissistic qualities hinder his or her everyday performance. The dysfunction may be associated with identity or self-direction, or trigger friction in relationships because of issues with empathy and intimacy. It may also arise from pathological antagonism characterized by grandiosity and attention-seeking. Narcissism is a continuum, and the disorder sits at the very end, Brummelman says. A personality disorder is a pervasive disruption in a person's capability to manage his or her feelings, keep holding on to a stable sense of self and identity, and maintain healthy relationships in work, friendship, and love, Malkin says. It refers rigidity. Someone who scores high up on the NPI may indeed encounter occasional awkward or stressful social interactions. But for someone with NPD, Malkin says, all the psychological defenses are working against healthy functioning all of the time. The lots of faces of narcissism. Pop culture has long relied on conceited traits to sketch problematic characters in sharp relief, from Dorian Gray to Don Draper. Gaston, from Disney's Beauty and the Monster, presents a ridiculous but relatively apt model of grandiosity, probably success, or all of the above. But it's a mistake to presume that all narcissists will be such apparent preenners. Not all narcissists care about looks or popularity or cash, Malkin says. If you focus too much on the stereotype, you'll miss out on warnings that have nothing to do with vanity or greed. For instance, he suggests, some narcissists can be of the communal variety and actually devote their lives to helping others. They might even agree with such declarations as, "I'm the most handy person I know," or "I will be known for the good deeds I have done." Everybody has met grandiosely selfless martyrs, self-sacrificing to the point where you cannot stand to be in the room with them, Malkin says. And there are highly reclusive or susceptible narcissists. Those individuals feel they're more temperamentally sensitive than others. They respond inadequately to even gentle criticism and really need consistent peace of mind. The way they feel special may actually be negative. They may see themselves as the ugliest individual at the party, or feel like a misconstrued genius in a world that refuses to recognize their gifts. What all subtypes of narcissist have in common, Malkin says, is self-enhancement. Their thoughts, habits, and statements set them apart from others, and this feeling of difference soothes them, just because they're otherwise struggling with an unstable sense of self. Narcissists feel superior to others, Brummelman says, but they're not always gratified with themselves as an individual. A link to depression. That struggle is at the core of a new conception of narcissism, one focused as much on sadness as on grandiosity. What people assume is that narcissists are prone to higher highs and lower lows, says Seth Rothenthal, a research specialist at Yale's program on climate change communication, who did his doctoral research on narcissism. They have this consistent need to have their success validated by the world around them. When reality overtakes them, they might respond by becoming depressed. When a clear obstacle, like a job loss or divorce or even a plan being scuttled, damages the thoroughly burnished self-image of an egotistical person, this is a very real attack on who he is, says Stephen Huprick, the president-elect of the International Society for the Research Study of Personality Conditions, and a teacher at the University of Detroit Mercy. Someone he thought was going to trust him now very much dislikes him and is unwilling to bear with him any longer. Not surprisingly, he finds himself a bit more down and depressed. Naturally, even people with healthy mindsets struggle to handle such dramatic turnarounds, Huprick says. But for narcissists and conceited characters, loss is truly very tough, just because it suggests vulnerability and weakness. It suggests that you actually aren't unsusceptible to life's difficulties and ups and downs. The narcissist might also show defensiveness and anger at such moment. When they don't get the appreciation they crave, they feel embarrassed and snap aggressively, Brummelman says. Others are not likely to have the exact same sort of aggressive outbursts. When a disappointment cuts through narcissists' thick layer of grandiosity and self-promotion and breaches their core, their resulting melancholy or boiling rage might inspire them to look for outside help. The Diagnostic and Statistical Manual of Mental Illness, DSM-5, in fact, advises medical professionals that individuals with NPD might present with a depressed state of mind. They hardly ever, though, come in seeking treatment for their narcissism. I've never ever heard anybody say, "I think I am a conceited personality," Huprick says. That doesn't mean narcissists are oblivious to their characteristic. A 2011 study in the Journal of Personality and Social Psychology, titled with a wink, "You most likely think this paper's about you," reported that narcissists did have insight into their personality. They described themselves as arrogant and knew that others saw them less positively than they saw themselves. However, they typically didn't see this as a problem, and the debate continues over whether the grandiosity shows an ironclad belief in their superiority or masks an underlying lack of confidence. Over years of research, Huprick and coworkers have developed a principle that might be connected to narcissism. They call it deadly self-regard. It's a perspective clarification for a constellation of not quite medically diagnosable personality disorders with overlapping functions, including depressive, self-defeating, and masochistic personality styles. Applied more widely to narcissistic subtypes, the notion suggests that deep-seated insecurity about the self and an extremely fragile sense of self-esteem can result in maladaptive ideas and conduct. Extroverted narcissists show grandiose attention-seeking. Susceptible narcissists, meanwhile, simply succumb to their damaged self-image. They're not able to keep a coherent sense of who they are, so when they are assaulted, rather than fighting, which is the first reaction of the grand narcissist, they have an instant reaction of unhappiness and deficiency and depression, Huprick says. People may develop deadly self-regard as kids in the setting of their relationships, Huprick proposes. Those individuals might have had irregular experiences with their parents or caretakers, related in specific to how success and achievement were recognized. Parents may have refused to acknowledge achievements or discouraged extolling them, removing the rose-colored glasses of healthy narcissism that could have reduced the way a child encountered new obstacles in life. Are they made or born? Childhood experiences might play a major role, but most professionals agree that both high levels of characteristic narcissism and NPD emerge from the combined impacts of nature and nurture that very likely start in the genes. There are characteristics we enter the world with, says Callie Tresnewski, a social development psychologist at the University of California, Davis. One's environment can either deteriorate or strengthen those characteristics, though there are always people who do not appear to respond to their environment. They're just sort of resistant to it. One twin research study found that narcissism was an extremely heritable quality. It can also manifest early in life. Another study found that dramatic, aggressive, attention-seeking young children were more likely to end up as narcissistic grown-ups. However, parenting styles, the influence of other relationships, and one's social and cultural environments can motivate or discourage its development. Culture matters also. Life rates of NPD have to do with 4 times higher in infamously competitive New York when compared to Iowa. Yet, across the globe, civilizations with a more collectivist tradition tend to put the group before the individual. You're taught from a very early age that you have to pay close attention to other individuals and put their needs before your own, says David Ludden, a professor of psychology at Georgia Gwinnett College in Lawrenceville, Georgia. Of course, there are narcissists in Japan and China as well, but they don't appear quite the same way as here, where we say, "Hey, it's okay for you to promote yourself." High narcissism isn't the same as high self-confidence. They are normally only weakly related, says Brummelman, who has studied how parenting methods can promote each. He and his associates found that when mothers and dads are warm and affectionate, hanging out with their children and showing interest in their activities, the children gradually internalize the belief that they are worthy individuals, the very core of self-esteem, and this does not spill over into narcissism, he says. By contrast, adult overvaluation, putting kids on a pedestal, does promote narcissistic characteristics. To stay away from raising narcissists, it's better for parents or caretakers to say to children, "You did a very good job," rather than, "You really deserve to win," or, "Why were not you as good as she was?" An early noticeable focus on success can lead to an insecure attachment between parent and kid, as a child learns that a mother's or father's love and attention are available only if high expectations are met. Children who feel they can never measure up can move into the adult years with a fragile ego and acquire egotistical ideas and habits to shore it up. Parents who raise narcissists, Ludden says, present to their kids a world where every little thing is a competition. There are winners and losers, and you have got to be a winner. A much healthier technique would be to teach kids that they don't need to be the best, just the best that they can be. Mislabeled millennials. No matter how hard parents try to guide kids from all-or-nothing competition, many ultimately need to vie for college admission, internships, and jobs. Shrinking chances might be what's contributing to a perception of raging narcissism among young people. When you set up highly competitive environments, you're actually encouraging people who are more ruthless, Ludden says. That's where the narcissists are going to flourish, because they are willing to do more to get ahead than the typical individual would. We've set up a civilization that encourages the narcissist, as opposed to one where that sort of conduct is discouraged. And so young people polish their resumes, update their LinkedIn profiles, brand name themselves online, and naturally flood social media with carefully postured, cropped, and filtered selfies. We have a lot more opportunities to reveal our conceited propensities than we once did, Ludden says. Many young people who may have discovered as rather modest in another time or milieu may just be trying to keep up and should have more of a pass of it. Our norms have changed, Trzynski says. If you took somebody from the 60s and put them in today's society, would they look any different? I would reason that they would be the same. A much better question, she suggests, is, why is there such a big trend to be negative about the next generation? This tendency returns to the time of Socrates, she argues. Older generations get scared when younger ones are doing things they don't fully understand. The question of whether narcissism, the quality or the disorder, is on the rise is a topic of fierce argument in the research community. For instance, while NPI scores have increased across generations, they have not done so as much as may be expected if a major cultural shift has taken place. Professionals also disagree on whether it's fair to make cross-generational contrasts. Would the greatest generation have become as significant for its reticence if fighters had had the ability to tweet from the European or Pacific theater? What is clear is that people are always more conceited when they're more youthful. Everybody is more conceited at 18, 19, or 20 than they are at 40, Trzynski says. It's a logical developing trend. Young adulthood is a time when people are mostly without responsibilities, either to their family of origin or the family they will eventually establish. It's an egotistical stage of life when you are attempting to find out who you are personally and expertly, says Emily Bianchi, an assistant professor of company and management at Emory University. Her research shows that generations exposed to difficulties, such as economic crises, tend to end up less egotistical than those that deal with fewer massive challenges. Economic crises seem to leave a humbling imprint on people who were young adults at the time, she says. That might mean that millennials, still struggling to establish themselves in a gradually recuperating economy, may actually wind up far less egotistical than pre-2008 information would suggest. On the world stage. History offers many examples of figures presumed to have had egotistical personality disorder. A Napoleon complex is essentially being egotistical, Rosenthal says. And if you look at video of Mussolini, he has a dominant, chest-thumping body language, a really physical manifestation of what we may consider narcissism. Evident self-assurance can propel a narcissist into power. If you're a great talker and people gravitate toward you, then your ego might drive you to seek that out, Rosenthal says. In the beginning, people high in narcissism, and the ones with NPD, can be quite lovely, easily attracting friends, lovers, and voters. Over time, though, their self-focus can become insufferable. People high on the egotistical scale tend to irritate friends and loved ones, at the very least sometimes, while those NPD might ultimately send them fleeing, serially costing themselves jobs, friends, and partners. Individuals find out that this is not so great, Rosenthal says. Having said that, many people with healthy levels of narcissism are incorrectly labeled as narcissists when interpersonal tensions rise. Whenever couples are in high conflict, they end up being more self-indulgent, Malkin says. Rage makes narcissists of us all. And when we feel hurt or upset, we tend to concentrate on our own psychic needs and struggle to show empathy toward others, both timeless egotistical habits. After a parent-teenager dispute or a fight between partners, the term narcissist may be tossed out, even when it never appeared suitable before. Another reason partners might label one another as narcissistic originates from how we match off in the first place, a narcissist being more likely to attract what Malkin calls an egoist, somebody who struggles with an absence of regular self-enhancement. They fear being a problem, so they can quickly end up partnering with their opposite and getting stuck in the relationship. One clue that a possible partner might be a narcissist? She claims to be great at every little thing, except relationships, Malkin says. Narcissists may reveal that they don't need anybody. They'll admit to choosing a prized spouse to true love, and they're not able to do the essential repair every relationship needs. Sparks of empathy? The impaired empathy aspect of conceited personality disorder can puzzle those that haven't been trained to detect it. A total lack of empathy would identify a demented personality, but people high in narcissism or with NPD exhibit flashes of empathy. The higher functioning narcissists have the capability to empathize, Huprick says, but eventually their own needs come first. The empathy is often shallow and short-term. They'll acknowledge that somebody else is suffering, but that will rapidly dissipate so they can get back to their own self-promotion. Within a relationship, narcissists may be able to show empathy till something disturbing happens, and they reflexively transfer to soothe themselves by putting a partner down. Even a partner is definitely worth sacrificing if it makes them feel exceptional, Malkin says. If a vulnerable self is the true foundation of narcissism, one way to strengthen it is with self-compassion. A survey of more than 3,000 people revealed that self-compassion resulted in more steady emotions of self-respect, instead of self-esteem, which has a more powerful association with conceited characteristics. An emerging body of research suggests that you can unclog the blocked empathy of people who are narcissistic by continuously focusing them on relationships, community, and connection to others, Malkin says. It makes sense. Unhealthy narcissism is a way of dealing with attachment insecurity. By increasing that security, narcissism drops. That might be the most appealing takeaway from the recent research on narcissism. Malkin says, "We used to think it could not be changed." A brief cultural history of narcissism. In DSM-5 Sweethearts, a sketch from the latest season of Inside Amy Schumer, a group of women gather to discuss recent relationships spoiled, each diagnosing her ex with significantly pathological disorders, and then attacking the one woman who suggests they might be off base. Slinging character conditions in table talk has never ever been more in style. It was not always that way. Narcissism was once a term used primarily in scholastic research and clinical analysis. Then, in 1979, researchers developed the Narcissistic Personality Index. Cultural historian Christopher Lass published The Culture of Narcissism, and the term went mainstream. In grad school, we discussed our narcissism freely, psychologist Craig Malkin says. In 2006, with Jean Twenge's book Generation Me, the idea that narcissism was on the rise nationwide and maybe rampant among the millennial generation in specific got in the public consciousness. Now some researchers are debunking claims of mass narcissism, expressing concern that a label meant to refer to a pretty serious scientific disorder is being wielded after each separation, family dispute, or selfie encounter. We may toss around the term way too much when somebody is just a bit of a show-off or ends up in charge, mental scientist Seth Rosenthal says. Such individuals might have personality traits that seem comparable to narcissism, but to truly certify as a narcissist, they need to have certain other inspirations and habits. Most concerning for some professionals is the thought of a cultural rejection of healthy expressions of self-confidence or self-esteem. Self-esteem is healthy, psychologist David Ludden says. Narcissism is something different. This has been Personality Disorders, a new perspective on bipolar disorder and narcissism. Written by Derek Halfson. Narrated by Rory Young. Personality Disorders. What paranoid, antisocial, sadomasochist, and sexual disorders have in common. Written by Derek Halfson. Narrated by Rory Young. Chapter 1. Paranoid Personality Disorder. The hallmarks of this personality disorder are distrust and suspicion. People who show constitutional fear don't usually confide in other individuals and often misread others, redefining innocuous statements and conduct as sinister. The paranoid personality disordered individual is suspicious of others. This individual thinks that others are out to threaten, betray, make use of, or damage. This disorder presents usually in the adult years. People with paranoid personality disorder are not typically grounded in reality, nor do they admit that they have negative feelings about other individuals. They mistrust people so much that they won't discuss how they feel, and harbor suspicions for lengthy time periods. Symptoms. Symptoms and signs of paranoid personality disorder as catalogued by the DSM-5. 1. Prevalent distrust and suspicion of others such that their intents are interpreted as malevolent, beginning by early the adult years and present in a variety of contexts, as suggested by 4 or more of the following. Suspects, without sufficient basis, that others are making use of, hurting, or deceiving him or her, is occupied with unjustified doubts about the loyalty or reliability of friends or associates, hesitates to confide in others just because of baseless fear that the information will be used maliciously against him or her, reads benign comments or events as demeaning or threatening, persistently bears grudging feelings like not forgiving insults, injuries, or slights, views attacks on his or her character or reputation that are not obvious to others, and is quick to react angrily or to counterattack, has reoccurring suspicions without justification concerning fidelity of partner or sexual partner. 2. Does not happen exclusively throughout the course of schizophrenia, bipolar illness, or depressive disorder with psychotic features, or another psychotic disorder, and is not attributable to the physiological effects of another health condition. Bear in mind, if criteria are met prior to the start of schizophrenia, include premorbid, like paranoid personality disorder, premorbid. Causes. Reasons for paranoid personality disorder as catalogued by the DSM-5. Paranoid personality disorder might be first obvious in childhood or teenage years. Most people who suffer choose privacy, have poor peer relationships, social anxiety, academic underachievement, hypersensitivity, peculiar ideas and language, and distinctive dreams. Those young people might appear to be odd or eccentric, and they're good targets for teasing. In scientific examples, this disorder seems more frequently diagnosed in males. There is some proof for an increased frequency of paranoid personality disorder amongst those whose relatives have schizophrenia. Some habits that are affected by particular life scenarios might be mistakenly labeled paranoid and may even be reinforced by the process of medical examination. Treatment. There are work treatments for paranoid personality disorder. Nonetheless, the person might haven suspicion about the mental health expert, which can hurt management of the disorder. Most people with paranoid personality disorder may suffer persistent fear if left without treatment. Therapy and some medications have shown to be efficient techniques. If untreated, the person may suffer problems at work and in the house. Comprehensive treatment can include both official and informal methods. Casual recovery might include self-help via family support, services for real estate, and vocational assistance. Use of medications for paranoid personality disorder is mostly discouraged. Medications may have an adverse impact with increased paranoia and suspicion, leaving the individual to forego treatment completely. If the individual suffers specific symptoms, such as serious anxiety or delusions that lead to dysfunction or self-harm or harm to others, medication is recommended. Anti-anxiety drugs like diazepam can be recommended if everyday function has been restrained. Antipsychotic medication, like thioradazine or haloperidol, may also be used. These medications should be recommended for the quickest period feasible. The most favorable treatment for paranoid personality disorder is psychotherapy. Many people who struggle with this personality disorder have typically knowledgeable difficulties that are ingrained and restrain interpersonal relations. A healthy therapist-client alliance will offer great benefit to the ones who suffer. The paranoid character disordered do not normally look for help, and they do normally cease treatment. Clients with this disorder can suffer for a lifetime and need regular treatment. Chapter 2. Antisocial Personality Disorder. Antisocial personality disorder defines a deep-rooted pattern of behavior in which people regularly neglect and breach the rights of others around them. The disorder is best comprehended within the context of the broader classification of character conditions. A character disorder is a long-lasting pattern of personal experience and behavior that deviates visibly from the expectations of the person's culture, is prevalent and inflexible, has a beginning in teenage years or early their adult years, is steady with time, and causes personal distress or problems. The symptoms of antisocial personality disorder can differ in severity. The more egregious, harmful, or dangerous conduct patterns are described as sociopathic or demented. There has been much dispute as to the difference between the two descriptions. Sociopathy is chiefly characterized as something badly wrong with someone's conscience. Psychopathy is identified as a complete absence of conscience concerning others. Some experts define people with this constellation of signs as stone cold to the rights of others. Effects of this disorder can include imprisonment, drug abuse, and alcohol addiction. People with this illness may seem lovely on the surface area, but they're likely to be irritable and aggressive and also careless. They might have numerous somatic complaints and maybe attempt to commit suicide. Due to their manipulative tendencies, it is difficult to tell whether they're lying or telling the truth. The analysis of antisocial personality disorder isn't given to people under the age of 18, but is given only if there's a history of some symptoms of conduct disorder before age 15. Antisocial personality disorder is far more common in males than in females. The greatest frequency of antisocial personality disorder is found amongst males who abuse alcohol or drugs, or who are in jails or other forensic settings. Symptoms. According to the DSM-5, functions of antisocial personality disorder include infraction of the physical or psychological rights of others, lack of stability in a job and home life, irritability and aggressiveness, absence of regret, consistent irresponsibility, recklessness, impulsivity, deceitfulness, a youth diagnosis or symptoms consistent with conduct disorder. Antisocial character is verified by a psychological evaluation. Other conditions should be ruled out first, as this is a very serious analysis. The alcohol and substance abuse typical amongst people with antisocial personality disorder can worsen symptoms of the disorder. When drug abuse and antisocial personality disorder exist side by side, treatment is more complex for both. Causes. While the exact reasons for the disorder are unidentified, both ecological and hereditary aspects have been linked. Genetic elements are presumed, since the occurrence of antisocial behavior is higher in people with a birth parent who shows antisocial attributes. Environmental aspects may also contribute, though, as an individual whose role model had antisocial tendencies is more likely to develop them. About 3% of guys and about 1% of women have antisocial personality disorder. Treatment. Antisocial personality disorder is one of the most challenging personality disorders to treat. People hardly ever seek treatment on their own and might initiate therapy only when mandated to do so by a court. There is no clearly indicated treatment for antisocial personality disorder. Recently, the antipsychotic medication clozapine has revealed promising lead to enhancing signs among men with antisocial personality disorder. Chapter 3. Dissociative Identity Disorder, Split Personality Disorder. Dissociative identity disorder, formerly referred to as multiple personality disorder, is characterized by an individual's identity fragmenting into two or more unique character states. People with this condition are usually victims of extreme abuse. Definition. Dissociative identity disorder, DID, is an unusual condition in which two or more distinct identities or personality states exist in and alternately take control of a person. Some individuals specify this as an experience of possession. The individual also experiences memory loss that's too extensive to be explained by ordinary lapse of memory. DID was called split personality disorder up until 1994, when the name was changed to reflect a better understanding of the condition, particularly that it is characterized by a fragmentation or splintering of identity, instead of by an expansion or growth of separate personalities. The signs of DID can't be explained away as the direct mental results of a substance or of a general health condition. DID reflects a failure to integrate numerous elements of identity, memory, and consciousness into a single multidimensional self. Generally, a primary identity carries the person's given name and is passive, dependent, guilty, and depressed. When in control, each personality state, or modify, might be experienced as though it has a unique history, self-image, and identity. The modify's attributes, including name, reported age and gender, vocabulary, general knowledge, and predominant state of mind, contrast with those of the main identity. Certain scenarios or stress factors can trigger a certain alter to emerge. The various identities may deny knowledge of one another, be critical of one another, or appear to be in open dispute. In many parts of the world, possession states are a regular part of a cultural or spiritual practice. Possession-like identities typically manifest as behaviors under the control of a spirit or other superbeing. Ownership states end up being a condition only when they are unwanted, cause distress or disability, and are declined as part of a cultural or religious practice. Symptoms. According to the DSM-5, the following requirements must be met for an individual to be detected with dissociative identity disorder. The individual experiences two or more distinct identities or character states, each with its own enduring pattern of perceiving, associating with, and thinking of the environment and self. Some societies describe this as an experience of possession. The interruption in identity includes a change in sense of self, sense of company, and changes in behavior, awareness, memory, perception, cognition, and motor function. Frequent gaps are found in the person's memories of personal history, which includes people, spots, and events for both the distant and recent past. Those recurrent gaps are not constant with regular forgetting. The signs trigger clinically significant distress or impairment in social, occupational, or other crucial areas of functioning. Specific identities might arise in particular circumstances. Shifts from one identity to another are usually triggered by psychosocial stress. In the possession form of dissociative identity disorder, alternate identities are noticeably apparent to people around the individual. In non-possession form cases, most individuals do not overtly show their change in identity for extended periods of time. People with DID may specify feeling that they have unexpectedly become depersonalized observers of their own speech and actions. They might report hearing voices, a child's voice or the voice of a spiritual power, and in many cases, the voices accompany several streams of thought that the individual has no control over. The individual may also experience sudden impulses or strong feelings that they do not feel control or a sense of ownership over. People might also report that their bodies unexpectedly feel different, like that of a small child or a person huge and muscular, or that they experience an unexpected change in mindsets or personal choices before moving back. At times, people with DID experience dissociative fugue, in which they discover, for example, that they have traveled, but have no recollection of the experience. They vary in their consciousness of their amnesia, and it is rather common for people with DID to minimize their amnestic signs, even when the lapses in memory are apparent and stressful to others. According to the Diagnostic and Statistical Handbook of Mental Disorders, 5th edition, more than 70% of people with DID have attempted suicide at least once, and self-injurious conduct is quite common among this population. Treatment is essential to improving lifestyle and preventing suicide attempts for those DID. Causes. Why some people develop DID isn't totally understood, but they regularly report having actually experienced severe physical and sexual abuse throughout youth. The disorder may first manifest at any age. People with DID might have post-traumatic signs, bad nightmares, flashbacks, or startle reactions, or trauma. Some studies suggest that DID is more typical among close biological relatives of individuals who also have the disorder than in the general population. Once a seldom reported disorder, the diagnosis has grown more common and questionable. Some specialists claim that because DID clients are highly suggestible, their signs are at least partially iatrogenic, that is, triggered by their therapist's probing. Brain imaging studies, however, have proven identity transitions. Treatment. The primary treatment for DID is long-term psychotherapy with the objective of deconstructing the different personalities and integrating them into one. Other treatments include cognitive and creative treatments. While there are no medications that particularly treat this disorder, antidepressants, anti-anxiety drugs, or tranquilizers may be recommended to help manage the psychological signs related to it. With proper treatment, many people who suffer by DID experience enhancement in their ability to operate in their work and personal lives. Chapter 4. Sexual Desire Disorder. Libido disorder is a psychiatric condition marked by an absence of desire for sexual activity over an extended period. In the DSM-5, libido disorder has been broken down into two separate conditions: female sexual interest arousal disorder and male hypoactive sexual desire disorder. Both of these refer to a low level of sexual interest, leading to a failure to start or react to sexual intimacy. This can include a lack of sexual thoughts or dreams, lowered or missing enjoyment during sexual activity, and missing or decreased interest in internal or external sexual hints. None of these conditions can be diagnosed if the primary problem is a desire inconsistency, in which one partner desires more sex than the other. Rather, the conditions are detected when signs have been present for a minimum of 6 months and cause scientifically substantial distress for the individual. Female sexual interest arousal disorder and male hypoactive sexual desire disorder can both be detected as generalized, meaning they might be a basic attitude to any potential partner or situation. These conditions can also be detected as being situational, suggesting symptoms are only present with certain types of stimulation, circumstances, or partners. Female sexual interest arousal disorder was called sexual stimulation disorder in previous variations of the DSM, although this diagnosis has been changed by gender-specific conditions in the DSM-5. The frequency of female sexual interest arousal disorder is unidentified, although some older women report less distress about experiencing low sexual desire than younger women. In guys, it is estimated that 6% of more youthful guys, ages 18 to 24, and 41% of older guys, ages 66 to 74, have some issues with sexual desire. Only 1.8% of guys ages 16 to 44, though, experience consistent problems lasting more than 6 months. Signs. Signs for female sexual interest arousal disorder include the following: absent or lower interest in sex, absent or decreased sexual ideas or fantasies, minimized or no initiation of sex, missing or lowered sexual excitement or pleasure throughout most sex, absent or minimized sexual interest or stimulation in reaction to internal or external hints, such as a partner's efforts to start sex, missing or decreased genital or non-essential sensations throughout sex. To meet requirements for female sexual interest arousal disorder, the signs should be present for at least 6 months and trigger significant distress to the individual. Signs for male hypoactive sexual desire disorder include the following: lowered or absent sexual thoughts or fantasies, lowered or missing desire for sexual activity. Comparable to female sexual interest arousal disorder, the symptoms should also exist for at least 6 months and cause significant distress to the person. Both of these conditions can be detected as a lifelong problem or an acquired issue that emerged after a period of normal sex. Causes. Changes in sexual desire are natural and may come and go depending on personal events or partner-related concerns. When the absence of interest in sexual activity lasts longer than 6 months and triggers distress, however, the criteria for a sexual desire disorder might be met. Some risk aspects for developing a libido disorder include lack of confidences about sexuality, relationship difficulties, poor communication, abuse, partner sexual performance, youth stress factors, medical conditions, diabetes mellitus, thyroid dysfunction, endocrine conditions, hyperprolactinemia, impotence, history of emotional or physical abuse, other psychiatric diagnosis, depression, anxiety, medication side effects, stressors, job loss, bereavement, alcohol use. Treatment. Treatment for sexual desire disorder might include psychotherapy and medication. In 2015, the FDA approved a medication called AUDIOBOOKS, flibanserin, to deal with gotten generalized hypoactive libido disorder, HSDD, in premenopausal women. The medication has faced debate, and research is underway to assess its efficacy. Treatment must be embellished. Some couples will really need relationship or marital treatment just before focusing directly on boosting sex. Of course, many couples may need to concentrate on the sexual relationship itself, and through education and projects, they can expand the variety and time dedicated to sex. When issues with sexual arousal or performance are factors, these sexual dysfunctions will need to be addressed. Prevention. One valuable way to prevent issues with libido is setting aside time for non-sexual intimacy. Couples who schedule time for one-on-one discussions are more likely to experience libido. Also, booking time before exhaustion sets in will motivate nearness and libido. Couples might mentally separate sex and love so that neither one is scared to be caring every day. Checking out books or taking courses in couples communication may also encourage emotions of nearness. For some couples, reading books or seeing motion pictures with romantic or sexual content might also serve to encourage sexual desire. Low sexual desire might be a barometer of the emotional health of the relationship. In the case of a loving relationship, low libido might trigger a partner to repeatedly feel hurt and rejected, leading to eventual feelings of bitterness and psychological distance. Sex is something that, for most couples, either bonds their relationship or develops a wedge that slowly drives them apart. When one partner is considerably less interested in sex than their companion, expert help is suggested before the relationship becomes strained. Chapter 5. Obsessive-compulsive personality disorder. Obsessive-compulsive personality disorder, OCPD, is a chronic condition in which an individual shows an excessive concentrate on details, order, and guidelines, and the need to attain a perfect result, typically in a way that interferes with life. They can be stubborn, firmly insisting that things should be done their way. The desire for order, excellence, productivity, and control can hamper their ability to end up tasks, to team up with other individuals, and to treat social activities or pastimes as simply recreational. In addition to demanding that others follow certain guidelines or meet high requirements, people with OCPD can be significantly self-critical. OCPD is just one of the most common personality conditions, according to the DSM-5. Occurrence estimates range from 2.1 to 7.9%. OCPD is categorized as a cluster C personality disorder, as are avoidant personality disorder and reliant personality disorder. Anxiety and fear are the functions shared by each of these conditions. OCPD is distinct from obsessive-compulsive disorder, OCD. While the disorders share features like a strong fixation with details and guidelines in some area of an individual's life, they differ in crucial ways. People with OCPD do not have undesirable ideas that force them to develop regimens or routines, as do the ones with OCD. On the other hand, people with OCPD experience their ideas and behavior as logical and purposeful. Their signs are steady across time, while symptoms of OCD usually change with time and in response to anxiety-provoking scenarios. Signs. Individuals with obsessive-compulsive personality disorder, according to the DSM-5, are overly interested in orderliness, perfectionism, and control, a pattern that begins by early their adult years and includes 4 or more of the following: a preoccupation with order and specifics that leads to the individual missing the point of an activity, perfectionism that hinders the completion of jobs, dedication to work and performance to an extent that's extreme and not clarified by financial needs. Excessive conscientiousness and inflexibility related to morality or values, not clarified by someone's civilization or religion. Failure to get rid of worn or worthless objects, even if they lack sentimental value. Reluctance to delegate jobs to or work with others unless things are done her or his way. Hesitation to spend money on oneself or others, and a belief that cash should be hoarded for emergency situations. Rigidity and stubbornness. People with OCPD may deal with difficulties in their work or social life associated to these symptoms. For example, they might delay starting or finishing a job because they cannot settle on the best or right way to finish it. A loss of control in particular situations may promote aggravation. Those with OCPD usually have difficulty expressing feelings of love and might be awkward with others' expressions of emotion. They might also not appreciate how their insistence on thoroughness adversely impacts others. While there is overlap between some signs of OCPD and those of obsessive-compulsive disorder, OCD, and they co-occur in some people, they are different disorders. And though OCPD can include hoarding-like conduct, the DSM-5 recommends that a diagnosis of hoarding disorder be reserved for seriously disruptive or harmful cases of hoarding. OCPD can also share some qualities with other character conditions, but there are very important distinctions. While people with narcissistic personality disorder may look down on the capabilities of others, for example, they're not likely to be self-critical in the way that those with OCPD are. Similarly, those other character conditions might be disinclined to give to others, but lack the financial self-constraint associated with OCPD. Causes. Research indicates that genes clarifies a significant amount of the risk of developing OCPD. The disorder also seems detected around twice as regularly in males as it is in females, according to the DSM-5. While genetics are an element, some theories posit that parenting style can guide a vulnerable individual towards the OCPD spectrum, particularly if the parent is highly controlling or protective, or highly punitive. In this circumstance, the personality disorder develops as a coping mechanism to keep away from punishment. Because OCPD-like behavior has been recorded in very young children, it is hard to evaluate the ways in which parenting and genes may engage to stir the disorder. Treatment. Some forms of psychiatric therapy might be useful for treating obsessive-compulsive personality disorder. There is some proof that cognitive treatment and cognitive behavior therapy, associated forms of treatment that seeks to attend to unhelpful ideas and habits, can lower the severity of signs. SSRIs have also been examined as potential treatments for OCPD. As is the case with all personality disorders, the ones who have OCPD might not experience it as an issue, but as a lifestyle. Many people with OCPD do not look for treatment just because they're not disturbed by the behaviors that define the disorder, and in some cases, find them beneficial. When people with OCPD do seek treatment, it might be just because they were referred by a member of the family, just because they have an obsessive-compulsive disorder, or simply because they experience anxiety about the failure to live according to their own guidelines and requirements. Chapter 6. Histrionic Personality Disorder. Histrionic personality disorder is identified by continuous attention-seeking, psychological overreaction, and seductive behavior. People with this condition tend to overdramatize circumstances, which may hinder relationships and cause sadness. Yet, they are highly suggestible, easily susceptible to the impact of others. Definition. Personality reflects deep-rooted patterns of behavior and the manner in which people view, connect to, and think of themselves and their world. Personality types are noticeable features of personality and are not necessarily pathological, although certain styles of personality might cause social issues. Personality conditions denote stiff, inflexible, and maladaptive patterns of thinking and acting, resulting in problems in functioning and/or significant internal distress. Most character conditions have their beginning in teenage years or early the adult years, are steady in time, and lead to significant inner turmoil or problems. People with histrionic personality disorder display excessive emotionality, a propensity to regard things in an emotional way, and are attention finders. Many people with this disorder are awkward or feel unappreciated when they're not the center of attention. Typical habits might include the continuous seeking of approval or attention, self-dramatization, and theatricality. Most people with histrionic personality disorder might act self-centeredly or sexually sexy in inappropriate circumstances, which includes social, occupational, and expert relationships, past what's appropriate for the social context. They may be dynamic and dramatic, and might at first charm new acquaintances with their interest, evident openness, or flirtatiousness. They may also, though, humiliate friends and acquaintances with extreme shows and tell of emotion, such as embracing casual acquaintances with passion, sobbing uncontrollably over small obstacles, or having tantrum. People with histrionic personality disorder commandeer the role of life of the party. Their interests and conversation will be self-focused. They use their physical appearance to draw attention to themselves. They tend to really believe that relationships are more intimate than they actually are. Their psychological expression might be shallow and rapidly moving. Their style of speech is excessively impressionistic and lacking in detail. They may do very well with jobs that value and require creativity and creative skill, but will probably have difficulty with tasks that demand logical or analytical thinking. Data from the 2001-2002 National Epidemiologic Study on Alcohol and Associated Conditions estimate that the prevalence of histrionic personality disorder is 1.84%. Signs. According to the DSM-5, for a diagnosis of histrionic personality disorder to be given, 5 or more of the following signs must be present. Self-centeredness, feeling awkward when not the focal point. Continuously looking for peace of mind or approval. Inappropriately seductive appearance or behavior. Rapidly moving emotions that appear shallow to others. Extremely interested in physical appearance and using physical appearance to draw attention to self. Opinions are quickly affected by other people, but difficult to back with details. Excessive dramatics with overstated screens of emotion. Tendency to believe that relationships are more intimate than they actually are. Is highly suggestible, easily affected by others. In addition, the signs should cause substantial disability or distress in a person. Causes. The reason for histrionic personality disorder is unidentified, but youth events and genetics may both be included. HPD takes place more frequently in women than in guys, although some experts claim that it is simply more often detected in women, just because attention-seeking and sexual forwardness are less socially acceptable for women than for guys. People with this disorder are usually able to operate at a high level and can do well in social and occupational environments. They may seek treatment for depression when their intimate relationships end. They often struggle to see their own circumstance realistically, instead tending to over-dramatize and exaggerate. Rather than being responsible for failure or disappointment, those the disorder generally cast blame on others. Just because they tend to crave novelty and enjoyment, they may put themselves in dangerous circumstances. Their conduct might lead to a higher risk of developing depression. Treatment. The recommended form of treatment for histrionic personality disorder is psychiatric therapy. That said, treatment for people with this diagnosis is often tough, because they may overemphasize their symptoms or capability to operate. They may also be mentally clingy and challenge the behavioral limits set up by the therapist. Therapy ought to normally be helpful and solution-focused. Because sadness can be related to unsuccessful romantic relationships, patients with histrionic personality disorder typically seek treatment when they're experiencing signs of depression. Chapter 7. Eating Disorders. What are eating disorders? Eating conditions are mental conditions characterized by unhealthy, obsessive, or disordered eating practices. Consuming disorders come with both emotional and physical symptoms and include anorexia, voluntary hunger, bulimia nervosa, binge eating followed by purging, binge eating disorder, binge eating without purging, and other or unspecified eating conditions, disordered eating patterns that do not fit into another classification. Consuming conditions take place more frequently in wealthy societies than in non-affluent ones, but they are not unique to the well-off. An out-of-proportion number of those detected are girls in their teens and 20s, but anyone, including young men and older grown-ups of any gender, can develop an eating disorder. Eating disorders usually end up being all-consuming, forcing the afflicted to focus on eating, or not eating, to the exclusion of much else in their life. Biological factors, social and social pressures, and family history are some of the factors related to eating conditions. Culturally mediated body image concerns and personality types like perfectionism and obsessiveness also play a very large role in the conditions, which are often accompanied by depression and/or anxiety. Treatment is seldom simple. Eating disorders may produce several additional health problems and can even be acutely lethal, requiring hospitalization and forced nutrition. It usually takes multidisciplinary teams of health professionals, consisting of psychotherapists, health physicians, and specialized dietitians or nutritionists, to bring about full healing. What causes eating disorders? There is no single cause of any eating disorder. It's not yet comprehended why ostensibly voluntary habits associated with eating become conditions for some people, but not for others. A disturbed relationship with food and a sense of emotional fragility, all hallmarks of all eating disorders. Consuming disorders generally begin unnoticed. An individual eats a bit more or a little less food than usual. The urge to eat more or to eat less ends up being significantly compelling, till it can become the focus of an individual's existence. Biology also plays a role. Appetite control and the regulation of food intake is highly intricate, with many hormones in the brain and the body signaling hunger and satiety. Proof also suggests that eating conditions have hereditary roots. Culture is thought to also play a considerable role, as people, women especially, are forced to fit a suitable of prettiness that's largely described by weight. Families contribute too. Parents or caretakers who stress looks, encourage dieting, or slam their kids' bodies might be more likely to raise a kid with an eating disorder. Other scenarios factor in too. The conditions can be activated by tension, social difficulty, isolation, depression, other unpleasant emotions, or by dieting itself. What is anorexia? Anorexia nervosa is an eating disorder marked by a severe fixation with weight loss or exercise. It's particularly prevalent among youth in middle-aged women and, progressively, among young men, but it can influence anybody at any age. Defined by a distorted sense of body image and severe voluntary starvation or overexercising, and closely connected with perfectionism and sadness, it is the most fatal psychiatric disorder. The most common behavioral signs of anorexia include severe dieting, obsessive food rituals, and secretive and antisocial conduct. Anorexia is highly resistant to treatment and is often accompanied by anxiety, stress, and depression. Treatment might include cognitive behavior therapy, medication, nourishment education and management, and family-based treatments, all of which may happen at specialized eating disorder centers. If the condition ends up being life-threatening, the only recourse may be hospitalization with forced feeding, which might produce moral and legal problems for all caregivers included. What is bulimia? Bulimia nervosa is an eating disorder marked by regular cycles of binge eating excessive amounts of food, followed by purging. Purging is generally done by self-induced vomiting, but might sometimes include the usage of laxatives, diuretics, or non-purging compensatory habits, such as fasting or over-exercising. The disorder generally starts throughout adolescence, but can also develop earlier or later. No matter age, it can be tough to recognize simply because those bulimia are usually secretive about their eating and purging habits. While many people with bulimia are overweight, they generally have an extreme fear of weight gain and usually suffer anxiety, sadness, and poor self-esteem. Signs of bulimia include uncommon eating behaviors, constant weight fluctuation, regular use of the restroom, and avoidance of gatherings. Treatment typically includes cognitive behavioral or other forms of psychiatric therapy, antidepressant medication, and nutrition therapy. What is binge eating disorder? Binge eating disorder is marked by persistent episodes of severe overeating not joined by countervailing behavior. As a result, those the disorder are normally overweight to overweight. People with this disorder tend to eat far more quickly than normal and don't stop till feeling uncomfortably full. They might take in large quantities of food even when they are not starving. They often eat alone because of embarrassment or humiliation over their eating habits. Many people experience periodic circumstances of binge eating and might even binge from time to time. To be considered a disorder, then, these behaviors should happen at the very least 2 days a week for 6 months or more. Are there other types of eating disorders? Though anorexia, bulimia, and binge eating disorder are the most popular, eating disorders encompass a number of other conditions also. These include avoidant restrictive food consumption disorder, rumination disorder, pica, and others. Avoidant restrictive food intake disorder is identified by the avoidance or limitation of food consumption. Most people with the condition may be withdrawn in food, perhaps attempting to avoid a negative experience they had in the past, or because they are unsettled by particular sensory characteristics of food, such as its smell or texture. Rumination disorder is identified by repeated regurgitation of food after eating, bringing previously swallowed food up into the mouth without displaying queasiness, uncontrolled retching, or disgust. The food is generally then rechewed and spit out or swallowed again. Pica is a condition characterized by the eating of one or more non-nutritive, non-food compounds on a regular basis, such as paper, soap, or hair. Those with the disorder usually don't have an aversion to food in general. Other eating conditions like night eating syndrome or irregular anorexia may be classified under other specified feeding and eating disorders in the DSM-5. Chapter 8. The Psychology of Sadomasochism. Sadomasochism can be defined as the taking of enjoyment, typically sexual in nature, from the inflicting or suffering of pain, challenge, or humiliation. It can include as an enhancement to sexual intercourse, or, less frequently, as a replacement or sine qua non. The infliction of strong pain and so forth results in sexual enjoyment, while the simulation of violence can serve to reveal and consolidate attachment. Indeed, sadomasochistic activities are often started at the demand and for the benefit of the masochist, who directs activities through subtle hints. Consensual sadomasochism must not be interchanged with acts of sexual hostility. While sadomasochists look for pain and so forth in the context of love and sex, they do not do so in other situations, and abhor unwanted hostility or abuse as much as the next individual. Typically speaking, sadomasochists are not psychopaths, and usually all the opposite. Sadomasochistic practices are very varied. One study identified 4 separate clusters: hypermasculinity, infliction and reception of strong pain, physical limitation, and psychological embarrassment. Remarkably, the study found that homosexual males tended more to hypermasculinity, while heterosexual males tended more to humiliation. Origins. Sadomasochism is a portmanteau of sadism and masochism, terms created by the 19th century psychiatrist Richard von Krafft-Ebing, who mentioned fundamental, natural tendencies to sadism in men and to masochism in women. More recent surveys suggest that vicious fantasies are just as common in women as in men, though it is actually true that guys with vicious urges tend to develop them at an earlier age. Krafft-Ebing called sadism after the 18th century Marquis de Sade, author of Justine, or The Misery of Virtue, 1791, and other sensual books. In the words of Sade, "How wonderful are the enjoyments of the imagination! In those delectable moments, the whole world is ours. Not a single creature resists us. We devastate the world. We repopulate it with new things which, in turn, we immolate. The means to every crime is ours, and we utilize them all. We increase the horror 100-fold. Masochism, Krafft-Ebing called after Leopold von Sacher-Masoch, author of Venus in Furs, 1870. Guy is the someone who desires, woman the somebody who is wanted. This is woman's entire but definitive advantage. Through man's passions, nature has given man into woman's hands, and the woman who does not know how to make him her subject, her servant, her toy, and how to betray him with a smile in the end is not sensible." While the terms sadism and masochism are of the 19th century, the realities they represent are much older. In his Confessions, 1782, the philosopher Jean-Jacques Rousseau discusses the sexual enjoyment he originated from youth beatings, adding that, after having ventured to say so much, I can shrink from absolutely nothing. He definitely didn't censure himself. To fall at the feet of an imperious mistress, follow her mandates, or implore pardon were for me the most elegant enjoyments. The Kama Sutra, which dates back to 2nd century India, includes a whole chapter committed to blows and sobs. Sexual relations, according to the Hindu text, can be conceived as a type of fight. For effective sexual intercourse, a program of ruthlessness is necessary. Early theories. The Dr. Johann Heinrich Maybaum introduced the first theory of masochism in his writing on making use of flogging in medicine and venery, De Usu Flagorum, 1639. According to Maybaum, flogging a man's back warms the semen in the kidneys, which leads to sexual stimulation when the warmed-up semen streams down into the testicles. Other theories of masochism centered around the warming of the blood, or the use of sexual arousal to alleviate physical strong pain. In Psychopathia Sexualis, 1886, a compendium of sexual medical history and sex crimes, Krafft-Ebing didn't connect sadism and masochism, understanding them as coming from different sexual and sexual reasonings. However, in 3 documents on sexual theory, 1905, Freud observed that sadism and masochism are typically found in the same individual, and, accordingly, combined the terms. He comprehended sadism as a distortion of the aggressive element of the male sexual impulse, and masochism as a type of sadism directed against the self, and a graver aberration than basic sadism. Freud said that the propensity to inflict and get pain throughout intercourse is the most typical and important of all perversions, and ascribed it, as so much else, to apprehended or disordered psychosexual development. He paid little attention to sadomasochism in women, either just because sadism was thought to take place mainly in guys, or because masochism was thought to be the normal and natural disposition of women. In Research Studies in the Psychology of Sex, 1895, the Dr. Havelock Ellis argued that there's no clear divide between aspects of sadism and masochism. Additionally, he restricted sadomasochism to the sphere of eroticism, therefore breaking the historical link with abuse and cruelty. The philosopher Gilles Deleuze asked to differ with Freud and Havelock Ellis. In his essay Coldness and Ruthlessness, 1967, he contended that sadomasochism is an artificial term, and that sadism and masochism are in effect separate and totally distinct phenomena. He provided fresh accounts of sadism and masochism, but sadly, I appear not able to make sense of what he wrote. Explanations. The exact same can be said for sadomasochism in general. Sadomasochism is hard to understand, perhaps, one of those great mysteries of the human condition. Here, I propose some analyses. Everyone might keep in some cases and not others, but none are mutually special. Certainly, lots of our greatest emotions can be triggered or co-triggered by more than one type of impulse. Most undoubtedly, the sadist may derive satisfaction from feelings of power, authority, and control, and from the suffering of the masochist. The sadist might also harbor a mindful or unconscious desire to punish the thing of sexual attraction, or a stand-in for the item of sexual attraction, or for an original item of sexual attraction, for having aroused their desire and therefore subjugated them, or, on the other hand, for having annoyed their desire or excited their jealousy. Sadism can also be a defensive strategy. By objectifying their partner, who is consequently rendered sub- or non-human, sadists do not need to manage their partner's psychological baggage, and have the ability to tell themselves that the sex is not all that significant, a mere act of lust rather than an intimate and pregnant act of love. Their partner ends up being a prize, a mere plaything, and while one can own a toy and knock it about, one cannot fall for it or be hurt or betrayed by it. Sadism might also represent a type of displacement activity, or scapegoating, in which awkward emotions such as anger and guilt are released onto another person. Scapegoating is an age-old and deep-rooted impulse. According to the book of Leviticus, God advised Moses and Aaron to sacrifice 2 goats each year. The first goat was to be killed, and its blood sprayed on the Ark of the Covenant. The high priest was then to lay his hands upon the head of the second goat and admit the sins of the people. Rather than being killed, this second goat was to be released into the wilderness together with its burden of sin, which is exactly why it came to be known as the scapegoat. The altar that stands in the sanctuary of each church is a symbolic remnant and suggestion of this routine, with the supreme item of sacrifice being, obviously, Jesus himself. For the masochist this time, taking on an important role of subjugation and helplessness can offer a release from tension, or the burden of responsibility or guilt. It can also evoke infantile emotions of vulnerability and dependency, which can serve as a proxy for intimacy. Additionally, masochists may derive pleasure from earning the approval of the sadist, commanding their full attention, and, in a sense, controlling them. For the couple, sadomasochism can be viewed as a means of heightening typical sexual relations. Real pain releases endorphins and other hormones, leaving a mark or memory, screening limits, giving form and expression to mental realities, building trust and intimacy, or simply playing. In her book, Aesthetic Sexuality, Romana Byrne presumes regarding claim that S&M practices can be driven by certain aesthetic goals tied to style, pleasure, and identity, and as such can be contrasted with the creation of art. A2. And what about you, dear reader? Maybe you think that this sort of stuff only applies to a small number of deviants, but the truth is that all of us harbor sadomasochistic tendencies. This is an example. Many casual, normal behaviors like infantilizing, tickling, and love-biting include definite traces and components of sadomasochism. In the words of Terence, I am human, and consider absolutely nothing human to be alien to me. Sadomasochism can also play out on a more mental level. In practically each relationship, one partner is more connected than the other. Typically, the more connected partner is the somebody that waits. In a fan's discourse, Fragments, 1977, the theorist Roland Barthes writes, Am I in love? Yes, since I'm waiting. The other one never waits. In some cases, I want to enact the one that does not wait. I try to busy myself in other places, to come late, but I always lose at this game. Whatever I do, I find myself there, with absolutely nothing to do, punctual, even ahead of time. The lover's deadly identity is exactly this. I'm the someone that waits. The very likely outcome of this asymmetry is that the less attached partner, A, grows dominant, while the more attached partner, B, ends up being infantilized and submissive in a quote to please, coax, and seduce. Sooner or later, A feels stifled and takes range, but if she or he endeavors too far, B might threaten to go cold or forfeit. That in turn prompts A to flip, and, for a while, to end up being the more enthusiastic of the two. Nevertheless, the original dynamic quickly reestablishes itself, till it is upset again, and so on advertisement vitam aeternam. Supremacy and submission are components of each relationship, or nearly, but that doesn't mean that they are not tedious, sterilized, and, to echo Freud, immature. Rather than playing at cat and mouse, lovers really need to have the confidence and the guts to rise above that game, and not just by getting wed. By learning to trust one another, they can dare to see one another as the fully fledged human beings that they really are, ends in themselves instead of simple means to an end. True love is about appreciating, nurturing, and allowing, but how many people have the capacity and maturity for this sort of love? Chapter 9. Do you have a personality disorder? The psychological health term personality disorder is getting used more regularly in general discussions these days. Lots of people really wonder if they have one, and some people might have been told they have one, which may or may not be accurate. A character disorder is specified by the diagnostic handbook used by mental health professionals as fundamentally an long-lasting pattern of inner experience or behavior that causes clinically substantial distress or problems in social, occupational, or other essential parts of functioning. There's more to it than that, but having an enduring pattern typically means that these problems will repeat and repeat for the individual without considerable change over the individual's lifetime, unless the person works hard at changing this long-lasting pattern. A lack of self-reflection. However, those a personality disorder don't tend to reflect on themselves to see the need and capability to change their conduct. That is why they're stuck. They feel helpless, vulnerable, weak, and like a victim in life, just as if our universe was out to personally give them a hard time. Lots of people with character disorders appear to have high conflict personalities, which means they have particular targets of blame, who they erroneously hold responsible for all their issues, such as their partners, children, parents, neighbors, co-workers, bosses, workers, and so on. By totally blaming others and truly lacking the ability to look at themselves, they continue their own behavior without changing. Thus, their issues and disputes continue or increase. All of their potential reflective energy enters into attacking their targets, who are often the people closest to them, and protecting their own behavior against all criticism and even useful tips. They might go from one relationship to another, one job to another, or can't even work simply because of such a devastating disorder. They often have few friends, but do not understand why. They don't try to change anything about themselves, which is the essential nature of a personality disorder. These two basic questions will help you consider whether or not you have such a disorder. Question number 1. What's my part in this issue? If you can seriously ask yourself this question, it is an excellent sign. That means that you are willing to take a pretty hard look at what your part may be in a dispute with another person, or just in obstructing your own progress towards an individual goal. Many people with personality conditions have the tendency to be not able to seriously look at themselves and their part in any problem. This does not mean that you are primarily responsible for a problem, but that you realize that you might influence it. For instance, in a divorce from a person who is violent, you might understand that their behavior was the primary cause of the relationship problems, though you also may find that your choice of partner was your part. By realizing this, you can analyze what attracted you to this individual in the first place, and take real responsibility for thinking about ways to pick a much better partner in the future. In another situation, you might have lent a good friend cash, and they disappeared with it. Were there warning signs you really missed? Should you have gotten some collateral to hold on to before lending the cash? Maybe you should not lend cash at all. Although you're not responsible for their behavior, you might find that there belonged you played in the overall situation, though small. Likewise at work, ahead of time your profession in communicating with colleagues, it helps to frequently ask yourself this question: what's my part in this problem? Question number 2. What can I do different next time? This follows straight from the first question. As soon as you recognize that you had power over some aspect of an issue, though small, you can plan how to stay away from or manage it in the future. Changing your own conduct is often essential to enhancing a circumstance you're in. This is what people with character conditions seldom do. They put all of their energy into feeling helpless, or attempting to get others to change, rather than attempting something different themselves. They might go into a rage, stay away from the situation, take a passive-aggressive approach, or try diversion. However, it's always something or another's person's fault, so they don't put any energy into changing their own long-lasting pattern. Some people have characteristics of a personality disorder, but still have some ability to self-reflect and some capability to change. They can take advantage of asking themselves these two questions on a more routine basis. Conclusion. If you can ask yourself, what's my part in this issue? What can I do different next time? And then act upon those questions to make a change, you are much not as likely to have a personality disorder. And if you do have a character disorder, you can begin asking yourself these two questions, and also seeking the assistance of a knowledgeable therapist. It is possible that with proper treatment, you can arise from this analysis and begin to have a more efficient and rewarding life.